Hello and welcome to this RCOA event. The webinar will begin shortly. During this event, you will be able to see and hear the speakers, but you won't be able to turn on your own microphone and webcam. To ask questions, click the Q&A button and type your questions in the window that appears. You can vote on other delegates' questions that you would like to be answered as well. We have enabled live auto transcription for this event. To turn the subtitles on and off, please click the button labelled Closed Captions. If you experience technical difficulties, we would recommend leaving and rejoining the webinar. If problems persist, please contact the events team. We are recording all of today's lectures and will upload these after the event. You will have access to the recordings for 6 months. Thank you for joining today, and we hope you enjoy the webinar.
Hello, welcome to the CPOC Perioperative Leads webinar. I'm Louise Bates, I'm a consultant anaesthetist and pre-op lead at Portsmouth, and I work at CPOC. And probably a lot of you have had an email from me over the last year or so. We're really pleased to be hosting this Perioperative Leads event. We know it's something that most of you have been keen to see restarted, and it's something that the college used to run a couple of years ago. Perioperative care obviously is an enormous topic. So the idea for today is that we've got 3 focused areas from the pathway. And then we've got people who've made this area work for them, and they're going to be giving short, sharp talks and then there'll be time at the end for you all to ask questions and get the information that you need so that you can try and make these areas work for you locally. If you do think of any questions, as it was just said in the video, please just put your question in the chat box at the side and we'll work through them during the Q&A sessions. We are hoping to run future events like this, focusing on other topics, and we will be asking for your feedback and what format you'd like to have it in. So that's enough from me. I'd like to welcome Dr. Kate Kanga from the CQC, who's starting the webinar for us today. She's going to be talking about perioperative care and the new CQC strategy and operating model. Kate's an ST7 anaesthetist at Guy's and St Thomas's in London, and she's a previous National Medical Director, Clinical Fellow at the CQC. Thank you very much, Kate.
Thank you very much indeed, Louise, for inviting me to speak today. I will just share my screen. Hopefully you should be able to see that. So thank you very much for inviting me to speak. As Louise has said, last year I worked for CQC as the Clinical Fellow as part of the National Medical Director Clinical Fellow scheme. And this year I'm continuing some of the work that I undertook last year. So I lead a group to develop a new perioperative care pathway inspection model. So this is a potential future way that we may well inspect perioperative care. Sorry, I'm just trying to move on the screen. I don't seem to be able to do that. There we go. Thank you. First of all, I thought I'd talk a little bit about what CQC does. So CQC is the Care Quality Commission, is the independent regulator of health and social care in England. So we're well known for our inspection programme, but this is only one of our functions. We also register health and adult social care providers, continuously monitor them, and then alongside this we inspect to identify whether they're safe, effective, caring and well led. And we publish what we find, including quality ratings. We use our legal powers to take action where we identify poor care. And also we speak independently. So we publish regional and national views of the major quality issues which affect healthcare. We encourage improvements by highlighting good practice. So an example of this is the provider collaboration reviews, which look at how health and social care providers are working together in local areas. So in April 2021, we published a provider collaboration review looking at cancer services and pathways. And these are some of the publications that we produce. So CQC provides a unique oversight of care across the system with a huge variety of care settings which are registered and regulated by us. And we use our data along with other information that we receive, so from people who use services, their families and carers, and this helps to inform our judgments of the quality of care. This is a list of the active services that we rate. This was as of July 2021. And actually we've got dentists here, but we inspect, but we don't rate dentists. We ask these 5 key questions, or what we would call key lines of inquiry. And this is at the heart of everything that we do. So CQC are undergoing a change in strategy, and I think it's an ambitious change. The health and social care landscape has changed dramatically since 2016, which is when our last strategy was published. And changes in the health and social care sector have, of course, been accelerated by the pandemic. So we're increasing the needs of those who access health and social care, but it also places additional challenges on service providers to meet them, as we well know. And our role as the regulator of health and social care has also been greatly impacted by the pandemic. And this has affected our ability to inspect all services and provide the necessary assurance to the public of their safety. So we're changing how we regulate to improve care for everyone. And what we've learned in the last 5 years puts us in a better position for the future. And this combined with, our strategy combines this learning and experience with valuable contributions from the public, service providers and all our partners. And it means our regulation will be relevant to the way that care is now delivered. We should be able to be more flexible to managing risk and uncertainty. And also it should enable us to respond in a quicker and more proportionate way. And this is as the health and care sector continues to evolve. And I think this new strategy strengthens our commitment to deliver our purpose, which hasn't changed. So that's to ensure that we can provide safe, effective, compassionate, well-led care and encourage those services to improve. And our strategy is purposefully ambitious. To implement it, we'll need to work closely with others to make this a reality. And we will continue to review this strategy regularly so we can adapt to the changes and be prepared for what the future may hold. So we have 4 key strategic themes, and we'll continue to build the underpinning systems and structures and make changes to this over the next 2 to 3 years. However, the full realisation of the strategy will take much longer as we continuously learn to evolve and adapt and responding to those changes in the health and social care landscape. As you can see here, we have 4 interlinked themes that will determine the changes we make. So the first one is about people and communities. So regulation, which is driven by people's needs and experiences, and focusing on what's important to people and communities when they access, use, and then move between services. The second key theme is about smarter regulation. So being smarter, more dynamic and flexible to provide up-to-date and high-quality information and ratings, easier ways of working with us and more proportionate response. And then safety through learning is our third theme, which is about regulating for stronger health and care services and prioritising learning and improvement. And it's about collaborating to value everyone's perspectives. And finally, accelerating improvement. So this is about enabling health and care services and local systems to access support to help improve the quality of care where it's needed the most. And as I said, this strategy is being developed over the next 5 years. So as part of this new strategy and linking in with our key themes, we're developing a perioperative care inspection framework. And this is a pilot at this stage where we can review a patient pathway across the system. So until now, we've inspected within core services rather than a pathway approach. So for a patient in perioperative care within an acute trust, this might include navigating through outpatients, diagnostics, surgery, critical care, medicine, and potentially urgent and emergency care services. We feel a pathway approach provides an improved perspective of patient-centred care. And from listening to feedback from patients, their carers, and the public, we understand that being able to navigate through that system with a point of contact for support and appropriate sharing of information is really important to people. With several national standards and guidance that we can talk to. So for example, we have the NICE Guidance 180, which was published in 2020, and the Centre for Perioperative Care, Diabetes, Patients Living with Frailty, Day Surgery Guidance. There's the GMC guidance on shared decision making, but this is amongst many others. And I think it's particularly important to emphasise that there is recognition of the current wide variation in perioperative care practice currently, and that pathways within different trusts will have varying degrees of maturity. And it's intended that this pilot is very much a consultative process. So whereby using an appreciative inquiry, we can build on improvements, socialise this new methodology, and provide help and support to improve care. And we expect this to take 4 to 5 years of phasing in, merging with CQC's new strategy. So our overarching aim for this pathway is to assess a whole pathway experience by a patient. So right from contemplation of surgery through to discharge into the community and rehabilitation. We aim to do this across primary care and adult social care also. However, the initial focus will be in acute hospitals as we build this pilot approach. We can assess the safety within the system, how services work together, and understanding the experience and outcomes of patients throughout their journey. So we'll include patient-reported outcomes. We can also assess how effective and seamless the experience is for patients, and highlight patient choice through shared decision-making process. And we want to be able to enable outcomes within these groups by protected characteristics, those with specific communication needs and action on health inequality. And it provides an opportunity to assess pathways based on local and national risk, in addition to testing trust-wide risk management and governance. It would reflect the robustness of trust leadership around safety, and we hope that it will highlight open and honest safety cultures. It may well expose risk at the interface between services, and we also want to focus on environmental sustainability. There's also the potential for a system-wide view as we build the ICS approach. And we have key overarching key principles, and that being shared decision-making, the interface between services and interdisciplinary working, amongst many others. So what do we hope this will look like? At least for our initial pilots, we've developed assessment stages across a pathway and a pathway tracking tool when we're on site. The initial stage involves a desktop review to gather information prior to in-person inspection and information from our national clinical audits, where we hope we can reduce burden on trusts. So this will include reviewing key metrics from our national clinical audits. And we also aim to review an elective, urgent and emergency pathway within each trust. So initially, pilot pathways will be selected using data-rich areas. So for example, using HES data, identifying high volume surgery, or surgery where GIRF data is available. And we aim to pilot this in several acute trusts over the next 2 quarters. Longer term, we hope to select pathways at local level based on where we identify potential risk. And this will be built using a risk-based intelligence model. We initially intend to publish best practice to drive improvements, and we won't rate, identify individual trusts, or publish individual trust reports during piloting. This is an iterative process, and we do not expect to get the pilots right first time. However, we do want to ensure that through conversations with our service providers and partners, we can line up the appropriate incentives and levers. If you'd like further information on CQC's new strategy, there are a number of ways that you can access information, as shown here. And as I mentioned, there are a number of publications. There's the publication I'd particularly like to mention is the new strategy, which has further information about the work that CQC is doing to build their new strategy. Please also feel free to contact me, and I've left my email address on the following slide. Thank you so much for your time.
Thanks very much, Kate. I think it's really great that people are starting to recognise pathways, and that's how patients experience things rather than the individual specialty. So that's really interesting. If anybody's interested in your work, you've left your email there, and if they perhaps were interested in being a pilot study for this as a way of helping them to develop their services, is that the best way to get in touch with you, just to email you directly, or is there another route in?
Oh, no, absolutely. I'd be very keen to hear from anybody that was interested in being part of one of the pilots. Please do, feel free to contact me through my email. Or if you have any further questions or thoughts, I'd be really interested to hear too. Thank you.
Thanks so much, Kate. Really appreciate it. It was a really great talk.
Thank you.
So I'm now going to introduce Jagdeep Desi. She is our Deputy Director at CPOC, and she's going to be chairing the first session today on perioperative care of older people. Thanks, Jagdeep.
Thanks, Louise, and morning, everyone. So really interested to kind of be hearing what Laura and Peter are going to be telling us in this next session, where we're going to be focusing on the whole pathway and thinking specifically about frailty, CGA, comprehensive geriatric assessment, but also kind of what really makes a perioperative physician. So first up, we've got Laura, who's a consultant anaesthetist in Ayrshire, and Aaron, and tells me that it's just as sunny up there as it is in Liverpool here today. So over to you, Laura. Thank you.
Thanks, Jagdeep. So thanks, Jagdeep, and thanks to CPOC for inviting me to speak today to describe some practical solutions to integration of comprehensive geriatric assessment in a low resource environment. By low resource, I mean where there's a lack of an obvious or direct route to the availability of key perioperative care team members with comprehensive geriatric assessment skills, such as a POPs team, and how alternatively we might utilise already established staff, then build gradually on this when the opportunity arises to improve perioperative care of the elderly. There's significant workforce and resource issues across Scotland with delivering a POPs team type service for CGA preoperatively. NHS Lothian here in Lilac have been exceptional in using the POPs approach to successfully improve length of stay and 30-day mortality, but 91% of referrals to their team were for non-elective surgery and required a team of 3 consultants, 1 specialty doctor and 1 nurse practitioner. And even with this resource, it didn't cover all surgical specialties. Sadly, despite these favourable outcomes, even the Lothian service is undergoing some fundamental changes due to lack of funding from the Surgical Directorate. Scottish Care of Older People is a multidisciplinary group led by Health Improvement Scotland, the British Geriatric Society and the University of Aberdeen, evaluating care of older people across Scotland. They did a CGA and acute hospital survey in 2019, concluding that only 27% had a specialist unit for this, that there was a large variation in the ratio of geriatricians to the older population of Scotland, and that liaison between care of the elderly and surgical specialties also varied and was largely focused on acute admissions to orthopaedics. In 2020, on behalf of CPOC, I surveyed all perioperative care lead anaesthetists in Scotland to inform an intended Scottish standard for perioperative care of the elderly for elective surgery. This concluded that only 8% of POM leads felt they delivered CGA prior to elective surgery, but despite this, over half reported that they screened over 65s presenting for elective surgery for frailty and were able to deliver shared decision-making discussions. There was also low levels reported of ability to communicate at-risk patients to post-operative destinations and awareness of delirium toolkits. By November 2020, I guess we were beginning to develop a Scottish standard for perioperative care of the elderly for elective surgery, and been asked to describe this to QI groups within Scottish Government and the Scottish Board of Royal College of Anaesthetists. The POP phase had 4 steps described: a frailty screen using the clinical frailty scale and 2 simple questions, and case finding using well-known scoring systems, including the Edmonton Frailty Scale and 4AT. And I'm going to show you at the end of these slides how we've managed in Ayrshire to integrate screening and case finding using logic with the assistance of a tech company to allow our POP assessment nurses to perform these steps. This screening phase would lead to referrals for comprehensive geriatric assessment, but we had to pause there and acknowledge the evidence of limitation from our own surveys in providing this in most centres. The final step in the preoperative phase is obviously providing a shared decision-making discussion by an appropriate perioperative consultant. Locally, in September 2021, we had a breakthrough in Ayrshire within the preoperative phase when a hospital-at-home geriatric service was funded, and this indirectly facilitated 1 session per week from a care of the elderly consultant, Rowan Wallace, who agreed to respond to these referrals received via a clinical frailty mailbox email from our nurse-led POP assessment or high-risk POM clinics. We referred 34 individuals over the first 6 months, and I acknowledge that this is a relatively small number of cases secondary to pandemic causes to elective surgery. The majority of these referrals have come directly from POP assessment nurses using the logic within our e-form. While there are learning points such as standardising documentation of advice from the CGA process, we've seen a gradual improvement to a 4.8 weekday response from our care of the elderly physician, with an average of 18 days left for optimisation and shared decision making between that advice and proposed date of surgery. And again, I acknowledge that this time between the care of the elderly advice and date of surgery is relatively short, but I think again that's a symptom of our current remobilisation following pandemic peaks. Encouragingly, 76% of our cases had a clear documentation of a shared decision-making discussion. In line with previous evidence from POPs, 14% of our highest risk older patients opted for conservative over surgical treatment. And review of these 5 cases concludes that these decisions have been appropriate and reached with a high level of support. I'm also encouraged with our surgical outcome data from this period, showing that there was no mortality during admission for surgery. 35% achieved same-day discharges from our day surgery unit. A further 30% achieved an inpatient length of stay that was impressively short with no immediate morbidity documented. And the 25% who perhaps had longer length of stays than expected, these all followed major surgery, only experienced minor post-operative morbidity, and in retrospective review, all had high-level shared decision-making discussions supporting their decision to proceed, and that hopefully avoids any decision regret. Moving on from the preoperative phase, this is our intraoperative bundle, described according to individual risk, with green and amber elements applied to all at risk and additional monitoring and technology applied to the most vulnerable. In the post-operative phase, improvement can be made through enhanced communication between pre and post-operative teams and increased awareness and application of the pre-existing National Delirium Toolkit. This phase highlights an auditable standard of performing 4AT by 12 noon on post-operative day 1 if hospital discharge hasn't occurred, and that's a standard that I would like to see go nationally across Scotland. I'm now going to demonstrate the logic that we've applied within our local POP assessment e-form in Ayrshire to facilitate the elements of the preoperative screen and case finding for referral for comprehensive geriatric assessment. This will require me to share a live version and demo mode of our e-form. So this is our e-form in a demo mode. The first thing that you'll note is possibly the patient's age. So they're clearly not an elderly patient. And the demo mode prevents me from changing that. If the patient was 65 years or older, then the frailty screen would automatically pop up within our e-form, and that's the first bit of logic. So if I scroll down to that section, if I scroll down to that section, if you had a younger patient that you wish to screen for frailty, then the pre-op nurse can select that section here, and you'll see that our frailty screen pops up. And the first thing that's got on it is the clinical frailty scale with a drop-down menu, which you can select from. And these two questions, the SQUID question and the question about if the patient has a current diagnosis of cognitive impairment. Now, if you select a clinical frailty scale of 5 or above, or you answer positively to either of these questions, you'll see that automatically the case finding aspect of our e-form appears, the Edmonton Frailty Scale, 4AT, and a list of delirium risk factors. And the logic in this part of the form means that if a patient meets the threshold within these 3 domains, then they'll automatically become a case for referral to comprehensive geriatric assessment. So if I demonstrate that using Edmonton, as soon as you go to an Edmonton score of more than 8, or a 4AT of more than 0, or you have 4 or more delirium risk factors, then the form changes the trigger so that the pre-op assessment nurse knows to refer for comprehensive geriatric assessment advice from the care of the elderly physician. There's a small prompt here to remind the pre-op assessment nurse to consider referring to some community resources for optimisation for frail patients. I'm now going to quickly scroll past our systemic inquiry part of our form, clinical examination and pharmacy, into this important section here, which is the section that involves referral both to a consultant anaesthetist for a shared decision-making discussion and also to the care of the elderly physician for CGA advice. So I hope I've managed to demonstrate that even in a relatively low resource setting, with some innovation and using the skilled and willing multidisciplinary state staff you already have, a pathway of some value can be developed perioperatively for people living with frailty. Our aspirations locally are to upscale our CGA pilot with remobilisation, move our screening phase to earlier in our pre-op assessment pathway, do more to enhance transfer back to the community, and maintain links with our local teams working with this same and unscheduled care. And when do this, we would meet the entire recommendations within the guideline for perioperative care for people living with frailty undergoing elective and emergency surgery from CPOC.
Thanks so much, Laura. I'm kind of struggling with the sun shining at my screen. I think what we'll do, Laura, I mean, that's a brilliant kind of oversight of how we can embed pathways, even when we don't think that we've got all the right kind of team members available. But I think what we might do is save questions as a panel, kind of after Peter's done his presentation as well, because I think there'll be lots of shared learning there. Thank you. So I'm going to hand over now to Peter Robinson, who is a consultant geriatrician down in Dorset. So we're going from the very north down to the very south. And we're going to be hearing Peter's views on what makes a perioperative physician. So over to you, Peter. Thank you.
Thank you so much, Jagdeep. Yes, I'll just share my screen and make a start. Oops. Okay, can you see that okay? Hopefully that's all good.
Yeah, that's good.
Yeah, great. Thank you so much for inviting me today. I'm really honoured to be able to talk alongside and to pioneers and leaders in this field. Yes, my name is Peter Robinson. I'm a consultant in geriatric and general medicine, and I'm the lead for Perioperative Frailty Service working at University Hospitals Dorset. So the objectives for this talk is to, I suppose, take a slightly light-hearted view. I should remind people as we go through the slides around kind of what is a perioperative physician and where they are, because I think we have a slightly different experience of the availability of some staff. It's really how we sort of are trying to sell our skills and services to meet the needs of our patients locally, and so to talk about our local service and experience. So this is what I think people sometimes think of about what does a perioperative physician have to be. My own experience is this still remains a slightly abstract concept, certainly in the minds of some of the senior clinicians. But I think we understand that it is there to fulfill a need that everyone now accepts is there, but perhaps are not quite sure how to meet it. I still consider perioperative physicians to be a slightly rare, if not mythical entity made up of this sort of super hybrid of all the best possible aspects of all the clinicians involved in surgical care. When I was asked to talk at this session, I was reminded of a conversation with a very senior surgeon who I won't name, sort of being involved in a conversation where they said, well, we don't really want a general physician. What we need is a perioperative physician. And I was a bit taken aback by that, because that was certainly different to what I think fulfills a lot of the roles for this service. But I suppose when I went away and reflect on it, the thoughts and questions that came up were, so what is it that you want? What is it that I think your patients need? But what do we have available to us at the moment? And I think this is a really pertinent question, particularly when we start looking at pathways and needs and how we can attend to this. So what have we got? And again, this is the light-hearted bit. I fear I may offend a lot of the people looking here today, but we have a lot of really highly skilled members of this team who traditionally provide part of this perioperative service, and not discounting our critical care physicians as well. But
Peter, sorry to interrupt. I think we can all see might not be on slideshow. We've got some of your notes and you're on your next slide. I don't know if that's just me that can see that.
Which slide are you on at the moment?
We can see your slide that says what have you got, and also your next one. So I think we might be on not slideshow view, if that makes any sense. It doesn't matter if it doesn't swap back. It's absolutely fine.
Let's try this. Apologies.
No.
Okay, I think I'll carry on if everyone can see the slides, if that's okay.
Interruption.
Okay, but does it matter? And I suppose, like I say, we've all become highly skilled, highly competent in our particular areas of care. But I think one of the things that is interesting, we all have our strengths, and I think we all have to reflect on perhaps some of our weaknesses based on our experience, our training, the environment with which we work on, and with that comes conscious and unconscious bias. Does it matter? Well, I think we have to have an interest and really critical, as has come up in the previous talks, do we have the availability to support this sort of service? People use the terms collaborative working and shared decision making, and I absolutely agree these are crucial things in terms of including with our patients. But this does require skill, patience, time and motivation. And to really do that, we talk a lot about silos of care, and I think we often are thinking about physical silos, how we work in separate areas, but I think there is an intellectual silos that needs to be broken down based on our very focused interests and within our subspecialties. And I think this is where you start thinking about, does a bespoke trained workforce, is that going to overcome some of these challenges about how we work collaboratively? And again, from my own personal perspective and talking to other sort of perioperative clinicians around me who provide this sort of service, kind of overcoming this, where we fit into this role as a physician or a geriatrician, you know, overcoming this imposter syndrome. Do we have the skills that are just as relevant as high excellent critical care, surgical and anaesthetic technique? So for me, it's who is currently placed to provide this sort of care, and then where does this future workforce come from? And we've shown this frailty pathway, which for me has been really crucial around looking at this whole pathway for our patients, very patient-centered, and how we design the workforce around that. And I think that's really crucial. When we start talking about frailty, complexity, comorbidity, understanding these principles is one thing. Recognizing it and facilitating this whole pathway, that's difficult. I think we intuitively, as human beings, understand some of the extremes of frailty, from the very frail to the very fit. What I think requires particular skill is trying to differentiate the sort of the more subtleties. One of the things I like about this Rockwood Frailty Scale is how it gives us a little bit more granular detail about this functional reserve that our patients may have. So differentiating the 3s, 4s, 5s and 6s, which can be really difficult if you haven't got experience in looking after these patients. Particularly the challenges when you see these patients who are sick in hospital. As I say, this requires skill and experience to manage and mitigate these risks. And again, with thinking about my own bias for my own background and training, what I think is really important is when we think about a shopping list of the skills and attributes that we want for a perioperative physician, particularly looking after an older frail population, but I think they have transferable skills in some of the younger, complex comorbid patients. For me, the geriatric specialist training curriculum is a really awesome shopping list for the kind of essential skills to be an effective perioperative clinician. So I think any sort of future workforce planning, I think there's a lot of already sort of very clear sort of curriculum data available. So then how do you sell it? How do you sell it to the people that you think need it? How do you free up the available staff to provide this care, because everyone is extremely busy at the moment? And how do you compete with the the other priorities within your trust? There is always something rather more shiny on the horizon that people want to have, and I always love this video, which I'm going to hopefully play, if it will play for me very briefly.
I see you have the machine that goes bing. This is my favorite. You see, we lease this back from the company we sold it to, and that way it comes under the monthly current budget and not the capital account. Thank you, thank you. We try to do our best. Well, do carry on.
So yeah, so how do you compete with that and even understand some of those, the financial priorities? I think that's really challenging. So look, let me tell you a little bit, without going to that video again, let me tell you a little bit about our own experience. So yes, I'm working on the South Coast. This is Dorset. This is essentially 3 hospitals which have merged in the last 12 months. This is Poole General Hospital, Royal Bournemouth Hospital and Christchurch General Hospital, which has merged to form one large trust, the Dorset University Healthcare Foundation Trust. And this is going through major sort of renovation, £200 million sort of renovation work, essentially to move most of the hot surgical and medical services to the Royal Bournemouth Hospital, where I'm largely based. It's a large hospital serving a large population, slightly spread out over Dorset, bits of Hampshire and South Wiltshire. And from a surgical point of view, we're a regional vascular cancer trauma centre, a major cardiology interventional centre, and doing quite a lot of orthopaedic work. And as I say, as the trust has merged and as the building work completes over to 2024, this will make us about the 5th largest surgical site in the UK. But currently, our work is still split between 2 sites, which has brought its logistical issues, and has been one of the drivers to centralise our services. So where I'm based at the Royal Bournemouth, we have what we call our surgical frailty service and the following sort of surgical subspecialties with very little orthopaedics. Poole General Hospital has a different subset of surgical specialities, but with a very heavy, all the trauma orthopedic work takes place there. So they have a very heavy orthogeriatric and silver trauma service. I think Poole Hospital is still the leading neck and femur fracture workload over a 12-month period. I think 1,000 neck and femur fractures per year. All of this will be coming over to the Royal Bournemouth in 2 years' time. And I guess to highlight is that we have 24 consultant geriatricians, not necessarily all whole-time equivalents, but the large majority have CCT'd in the last 5 years, and so their skills and the training has been received as around perioperative medicine has been is quite fresh in our minds, I suppose. A lot of the transferable skills of, I would argue, for orthogeriatrics and silver trauma can feed and support the perioperative care of all surgical patients. So a little bit about our own history. So the surgical frailty service was developed before I arrived in the trust in 2020. I sort of surfed the COVID wave out of London on that year to the south coast. In 2018, it was formed on the back of some quality improvement work in vascular and prior to that colorectal surgery. And they both had quite similar kind of models of care as an embedded consultant geriatrician leading an MDT within these surgical subspecialties. And each of them showed some process improvements around length of stay and quite big differences in readmission rates within 30 days. And it was on the basis of that that they developed this business case. So the team structure. So what is our surgical frailty service? Essentially, it is a consultant, myself, a consultant geriatric and general medicine, sort of paid sort of essentially 0.5 whole-time equivalent with a little bit of goodwill thrown in. We have this quite nice balance of advanced care practitioners from a nursing therapy background. We have our discharge coordinators, particularly helping with the complex discharge work that takes place, our own administrator, and we've got a 1-year funded clinical fellow from Wessex Deanery who's working as an OP with us. And we have a perioperative MDT clinic that we run once a fortnight. I'm going to mention very quickly, this is our flyer that we use for the surgeons. I don't think anything very controversial about our referral process, aged over 65, under a surgical care pathway. We've actually used a Rockwood score of 4 or above to keep our referrals a little bit broader. We've always feared being overwhelmed with referrals if we set the bar too low, but I think what has allowed us is a little bit of clinical decision making. And I might, if there's time, talk a little bit about sort of the scoring system and how that and how we still may support people with those sort of milder end of frailty spectrum. It is only funded for Monday to Friday, 9 to 5. We're heavily embedded with the vascular surgeons. We do so combined ward rounds with them 3 times a week, and we see all the referrals across the surgical directorate. And as I say, we're really using CGA as our sort of template to provide this care for patients who are defined as frail, and we're using the Rockwood Clinical Frailty Scale and age as a fairly crude cutoff to see those patients, setting their bar relatively low. And we have a weekly MDT across the directorate, particularly with the allied health professionals, and we have this perioperative frailty MDT clinic once a fortnight. Now, I don't have time to talk about this, I don't think, in any great detail, but we're really proud of it. This is sort of one of the reasons I wanted to join this trust, that it had a relatively well-developed service working with 2 of our consultant anaesthetists, but a really quite well-funded and well-supported, truly multidisciplinary team. We've only really started it up again because of COVID issues since September of last year, but we've been seeing a nice sort of range of ages, frailty, and surgical subspecialties, but really interesting sort of the frailer spectrum of patients we're seeing. About a third are sort of proceeding with their surgery, a third or so requiring further investigation and optimization, and interestingly, sort of a third opting not to go forward with any further intervention after sort of going through this sort of shared decision-making process. And so that's been really interesting, something we want to look at in a little bit more detail as to the reasons why patients eventually decide that actually they didn't want to go through with any major surgery. I think I could probably skip through this pretty quickly because I'm sure you're all very familiar, but COVID has had a huge impact on what is a relatively small team, and we've had to be quite flexible and pragmatic. I think what has been really important is to still advocate that this service has still been important throughout the COVID pandemic. The surgical demands, the emergency surgery has still been ongoing, and actually maybe some of the acuity has been higher due to delayed presentations. And of course, the huge backlog in planned care, particularly sort of aneurysm, limb revascularization, cancer waiting lists is a major focus for the Trust now. One of the things I always like to talk about, particularly to our sort of clinical leads in surgery, is, we don't just see patients, we support a lot of the morbidity, mortality, governance, complaints, which I think has been really useful. We're helping out with national and local quality improvement work, and particularly our own local work around the NELA standards has been really useful, which I might mention very briefly in a second. We're trying to look at the impacts of prospective CGA assessments when we see them prospectively and proactively rather than waiting for a referral downstream. And we're really trying to get our surgical doctors and nurses to be prospectively assessing frailty at the front door. And we've developed some sort of research and innovation connections locally. Just talk briefly through our achievements. We've worked with our anaesthetic department through recent inspections, and our service has been commended to go onto the RCA Good Practice Library, which we're really proud of. And as I say, we've done some impactful quality improvements, which I can't go through in a lot of detail at the moment, but really about how we practically apply CGA comprehensive assessment at the front door, and how we apply to some of these sort of national standards around NELA to make sure we're seeing all the patients that are really deemed high risk. I think I've talked a little bit. I think those are our strengths. We're a small but a cohesive but nicely balanced team. We have a lovely database for audit and research purposes, and we're really strongly supported by really all the clinical and managerial leads, particularly at this time of transformation within the Trust. This has been an amazing opportunity to help shape the future design for the Trust and the services. And of course, we have a large cohort of newish consultant geriatricians, a lot of them with an interest in perioperative care of older people. To have that sort of backup has been really crucial, I think. And our challenges, I think was alluded to a little bit earlier. We want to provide a comprehensive and holistic service to both sort of elective and unplanned care, but that is time and resource heavy, and so the depth of that comprehensive assessment does need to be somewhat fluid, dependent on the need of the patients, but also the time and staffing we have. Trying to increase or upscale our service has been quite challenging with very limited resources. I mentioned briefly this idea of sort of the frailty score, and I know maybe this is controversial, but we do think there's a potentially missed opportunity if we screen too low, particularly in the older, complex, comorbid patients who are being defined as previously as vulnerable on the Rockwood Frailty Score or very mildly frail. These patients we think are more likely to undergo a major intervention. And so although their physiological reserve may be greater, they're often undergoing a greater physiological stressor. And so I think you can't disconnect those two things. So sometimes having that information is quite useful, and we feel that we can support those patients well, but they are more hard to identify. And the other thing to reflect on, we see quite a lot of relatively young patients, perhaps in their late 50s, early 60s, who really have the same frailty phenotype, particularly with lifestyle and disease factors in their past. And I think we have to be a little bit fluid about that age cutoff. I think I'm running out of time, but I think the skill mix of the service is really important. I don't think this is always going to be a doctor-heavy service. I think it's going to require, a broad support and a broad skill mix to deliver this in the future. And how we deliver that, this liaison versus how you co-manage, embed with the surgeons, I think has also been a challenge for us. We know from our work and from other national work that actually being embedded with a particular service is the most effective and brings about the most effective intervention for patient care and for some of those process measures. But this is much more time, staffing, intensive, and I'll be really frank, is not always desired from our consultant colleagues. So not everyone wants to work like that, and so I think there is some practicalities and pragmatism that is required there. One of the ways we've tried to look at this locally is to really upscale, particularly this perioperative assessment, to really somehow industrialize this in some way with this healthcare pop-up village that has been created. So this is sort of looking at the really big picture, thinking big, and really to try and overcome some of this sort of elective waiting lists and access some of the emergency recovery funding to really try and get on top of some of these waiting lists. How we, as a slightly more labour and time consuming service, how we can support that, I think we still need to come look into. So yeah, so this has been really the key, and I'm really grateful to all these sort of public bodies, all these audits, and particularly with CPOC, in terms of giving us some really illustrative, consistent evidence-based messaging which we can take from these national groups and the Royal Colleges, and we can talk and keep hammering this message with the clinical leads and essentially the executive board to try and make some progress to develop what we think is the best possible service. So yeah, so I guess my summary is, there is an existing workforce. I think we have the skills to attend to a lot of this care pathway, but I think for us, funding is the really challenging issue. But I think with compelling patient safety and efficiency data, I think this really strongly supports this model, and I think for us, we're really getting a lot of traction now in the trust. One wonders if, for a really truly sustainable, consistent, and effective model, that some sort of formalised specialist training pathway is probably going to help break down some of those intellectual silos. But again, I think this is a really attractive field to attract people from a broad background, whether it's a doctor background or from nursing background. I think that's really important. I think there's a lot of enthusiasm to provide this sort of care. I'm going to finish with a thank you for your attention. I'm sorry if I've overrun a little. It's a little thing, more is never enough. These are the words of my young daughter, but also my words I continue to say to our clinical director, but she's very patient with me. But thank you for your time, appreciate it.
Oh, thank you so much, Peter. And welcome back, Laura. So we've got 20 minutes or so for some discussion, and there's been some questions in the chat there as well. And I think kind of the questions really kind of look like they are arranged around two broad themes. Firstly, around shared decision making. And of course, we know that kind of from the evidence reviews that CPOC has done, that around about 1 in 7 patients express decisional regret after having had surgery, major surgery. And we're seeing similar kinds of numbers, 1 in 7 in your work, Laura, and similarly in ours, and kind of pretty similar from Peter's, patients choosing not to go ahead with surgery once they've undertaken formalised shared decision making. But some of the questions in the chat are very much around the practicalities of shared decision making in this whole pathway approach, as to who needs to be in the room for those discussions, how do we facilitate that, how do we make sure that the right people are there and contributing effectively. So Laura, do you want to reflect on your practice around shared decision making firstly?
Yeah, so I think as anaesthetists with an interest in perioperative care, we always see the ideal, it's always put forward that you would be in the room with the patient, a supporting person if the patient wants it, a surgeon and an anaesthetist side by side, but often, job plans don't allow that. So I think you've got to be able to flex to that when required, but accept that it's probably not something that you can set up as standard. So if I was to give a local example for each, then our breast surgeons, so you'll be aware that the older and most frail of our patients sometimes have that endocrine option. So they've got 3 choices. They've got the do nothing choice, which not very many of them are going to choose for a malignancy. They've got an endocrine treatment option, which can hold their malignancy for up to 5 years, and they've got the go ahead for surgery option. And our breast surgeons have kind of worked with me over the last 3 or 4 years so that they have a kind of standard referral letter, either by email or by formal referral, and they'll refer into my session, which is seen as a high risk kind of POM clinic. And I have a standard way of replying to them, which they've got used to, detailing comorbidities, the possibility of optimization of these. I use ACSNS QUIP as standard to give them those kind of outcomes for mortality, morbidity, chance of discharge to rehab, and the kind of the frailty outcomes, functional decline, and chance of post-operative cognitive dysfunction. And I send that back to the patient's GP and the breast surgeon. And then the breast surgeon and the breast cancer nurse will sit down with that patient and kind of try and come to a decision. If the patient expresses a definite choice at the end of their appointment with me, I will put that in the letter, but make sure that the patient knows that they've got more time to kind of come to a final decision. So that would be an example where we're not in the room together. With the colorectal surgeons locally, often that being very major body cavity surgery, I've sometimes done CPET for those patients. I don't find CPET really useful for the most frail patients, but if a patient can cycle, we sometimes use that. And then often for those individuals that are seen as very high risk, when their options are often just going ahead with surgery or conservative treatment, I do try and often sit in the room with a surgical colleague and the patient once the kind of fact finding, information gathering part is done. So I think you've got to recognise what building blocks you have within your service, have a kind of standard approach depending on the surgical type, but be able to flex. And that's all about relationships with colleagues and them understanding what it is you're trying to achieve together.
That's really helpful, Laura. And I think that also kind of feeds into some of the work that's now underway at CPOC with primary care as well, because of course the shared decision-making process really starts kind of right out there in the community. And it's about kind of sowing the seeds, isn't it, in that first discussion when the GP's referring a patient in and talking about referring in for a surgical opinion as opposed to for surgery, so that then people are open to the fact that there may be a variety of different options that are provided to them, and then having the opportunity to discuss that, which of course we're kind of supporting through, again, some of the work at CPOC. Some of you may have seen the animation, which is up on the website, around shared decision making and initiating those early discussions. Peter, anything else to add to that?
Yeah, thank you. Yeah, it's really interesting. One of the things that we struggle with is we don't have a surgeon present in our perioperative clinic, and I always find that is a disadvantage, because one of the key parts of that decision-making process is talking about the need for surgery, I suppose. What are the alternatives? Is this surgery a symptom-based thing, which I think is much more patient-centered, or is it based on perceived prognosis? And that everyone has slightly different perspectives on that. So having these clinics without a surgeon present, I think, is quite difficult. And all we end up doing is then conversing directly with our surgeons and trying to get and feeding back what we had, which is not ideal, and then becomes more time consuming. I like the comment earlier was, what we say in the clinic is not the end of the conversation, but then we don't have a lot of further conversations. Then it is more left between the surgeon and the patient. I think they heavily rely on this clinic to say, well, if they decided this wasn't the right thing to do and the patient agreed, or they were part of that decision, then we're happy not to proceed. But I think it is incomplete. So I think there's some more work to be done there. Yeah.
Well, there's always more work to be done, isn't there? But one of the other things that we've also found really useful is actually starting to put a shared decision-making box into our clinic letters, and certainly a number of the other units as to setting up, put in benefits, risks, alternatives, nothing. And actually kind of populate that, not just with the surgical risks, but the risks around cognitive change or functional decline as well. And I think you're right that often it ends up being those conversations, doesn't it? You end up having all of the team on speed dial on your phone, and you're able to step out of a consultation, go and chat to one of the surgeons, and then try to relay that information back. But it is an ongoing process, isn't it? Shared decision making. It's not a one-off conversation. It needs to be continual. So great kind of practical pointers there for people listening in. the other kind of comments which are really kind of coming out in the chat there are, you know, of course, I think what's been really nice about the session this morning is that we've talked about a kind of Laura trying to deliver this with a kind of skeletal team to some extent, and trying to put in processes to address some of the gaps that exist in the workforce. And then Peter probably being more at the kind of same end as us at GSTT with having a bigger team available. But of course, that comes with its own challenges, and it's never enough anyway, is it? There's always more work to be doing. But any kind of, and one of the comments has been about how do we reconcile the need for frailty specialists with the need for specialist anaesthetists working within certain subspecialties? And are we going to end up just throwing more people at a pathway and making it more disjointed through that? So Peter, do you want to take that first?
Yes, yeah, that's interesting. I suppose I don't quite see the link of making it more disjointed. So certainly what I found that, you know, there are a subset of anaesthetists who have a particular interest. You know, we have two that are linked to our clinic, but at the same time, there's sort of a wider body around that, particularly the ones who are providing CPET testing. We've got quite an active CPET department. I'd echo some of the thoughts about how useful it is in some people, actually, but it does give an incomplete assessment in some ways, which I think we all recognise. Look, I find with the anaesthetist, that is where you have some skills that they have that I don't have the same insights that they do, and I think, but you need a cohort of anaesthetists who also have an interest and are willing to come to clinics. I think those were the two core parts of our clinic to really help assess those patients, because it's that risk assessment that is so crucial, and it's beyond some of the standard anaesthetic risk assessments, particularly around frailty assessment, which is another risk assessment, delirium assessment, cognitive assessment, in a bit more detail. So I think that's really important. But then the bits that we add to that, I think, is particularly around kind of the optimization or prehabilitation that I think we're able to take a bit further. And this relates to one of the other questions, is then we also then have that continuity where that anaesthetist may have relatively limited further input into that patient. We're able to see them not during the anaesthetic and surgery themselves, but on the day of surgery, maybe able to see them prior to their operation. But that is usually a hello and good luck, but then follow them up as soon as they get out of recovery and onto the wards, and that's where we can really sort of pick them up. So that continuity is really crucial. So I don't see the anaesthetic input necessarily fragmenting that, but of course everyone is very busy, and how do you pull those people that are so busy in their core areas into this area, which is also so crucial? It hasn't been a major conflict for us so far.
And Laura, any comments on kind of the need for that kind of maybe more transdisciplinary workforce that has got a shared skill set across some of these areas?
I think as long as your assessment tools at whatever stage, you know, if you're lucky enough to be able to start them off in primary care, if you're not, you know, it's after the point that a decision that surgery may be indicated that is made, then as long as you case find everyone that has need, as long as your system is sensitive enough to case find everyone of any age that's of need for that kind of higher level of input, then, you know, you're delivering. So frailty is one way of case finding, you know, that we've demonstrated today, using, you know, tools to pull out risk scores, to pull out the kind of the frail population, and then having a standardized approach in some way to that. But your under 65s, or, you know, those that aren't frail still need to get picked up. So that's about how major is their surgery. You know, we've got DASI scoring within our document. We've got graded responses to certain comorbidities like diabetes or obstructive sleep apnea, you know, so you need tools to pull out under kind of different high risk headings. I don't think, so in our health, in the hospital I work within our health boards, we've got 5 consultant anaesthetist sessions in pre-op assessment, and we've got one of those sessions identified as a high risk clinic. So that can't work in a silo separately from the frailty pathway. So the trigger to get reviewed by an anaesthetist happens at the same time as the trigger for CGA, and then it's a case of a kind of communication and handover between those two people or those two pathways until we feel we've met the patient needs. Our shared decision-making discussions, having a look at the last 6 months in that frail population, have been largely led by an anaesthetist or a surgeon, actually, which is great to see. And a couple of them have been care of the elderly led. So it's just having, again, that flexibility and making sure all the higher risk patients that have need are identified and kind of their needs met.
Yeah, no, that's great, Laura, and that probably resonates a little bit with what Miriam has also put in the chat about how we can start some of this segmentation of the population really early in the pathway from the point of referral, so that we're getting that information flow in, we're screening appropriately, case finding, and then using whatever workforce we have to be able to assess and optimize as required as well. And that probably does really lead in really nicely into another question, which is about, okay, so you've screened and found people with frailty, but what can you actually kind of do about it? And probably the theme for kind of a whole day's talks, isn't it? And actually kind of, I'm at the RCP today in Liverpool, and there's a whole session on modifying frailty this afternoon. So I'm sure that people could dial in for those talks. But Peter, any quick kind of summary of what happens once we identify frailty?
Yes, well, yeah, the CGA kind of template is what we look at, but the quick wins, I suppose our biggest focus is on physical function, so physical prehabilitation, nutritional prehabilitation, and kind of that medications reconciliation. And those are really easy things to say. And some of the, I guess, the hemopoietic optimization, which is actually very standardized around the country around iron infusions and things like that. But it's the medication optimization of comorbidities, I think, is relatively straightforward, particularly with a clinical pharmacist for us. Without the need to then refer necessarily automatically to subspecialists, respiratory, cardiology, renal. There's a lot that we can do within ourselves. But I think the physical function, the nutrition, is something that we particularly focus on. So I think that's the real key to picking these people up proactively before their surgery, because I think there is a window for doing something. The stress, of course, is trying to do that in a timely fashion, particularly on a cancer pathway.
Yeah, and certainly the latest data from looking at CGA, certainly within the elective setting, is showing that we're making around about 2/3 of patients presenting to those services have a new diagnosis made at that assessment. So lots of unrecognised disease amongst that group. So lots of unrecognised multimorbidity, with 3/4 needing their medicines changed. So there's a lot of general medicine that's involved, and often this is around heart failure, blood pressure, ischemic heart disease, all the usual kinds of comorbidities that accumulate with aging. So lots of general medicine alongside some of the components which I suppose make up traditional prehab in terms of exercise, nutrition, smoking and alcohol cessation, and counselling, which have always been part of CGA, because of course it has this multi-domain approach to medical, functional, social and psychological issues. And I think one of the things that sometimes gets lost for people who don't come from a geriatric medicine background is that, of course, CGA is a bit of a misnomer, because it sounds like you do the assessment and then stop. But the real bit of it is the optimization. So we do need to start to think about CGA and optimization within that. Laura, anything to add from your reflections as an anaesthetist delivering CGA?
Yeah, I think anaesthetists always kind of reflect on that perioperative pathway. So the pre-op, the intra-op and the post-op parts. And the pre-op part, I guess you're trying to identify what domains within frailty you can optimize against. So if you think of the Edmonton scale, for instance, then that very clearly gives you domains to work from. And I imagine what our geriatrician or care of the elderly colleagues are doing are kind of honing in on that in more detail to identify the possibilities for optimization. Yeah, obviously you're trying to apply prehab principles that you would apply to a patient of any aging that's considering surgery, and you're wanting to identify those key comorbidities. And the intraoperative phase and the postoperative phase is making sure that everybody that the patient's going to meet on the pathway is aware of them being a case of risk that's been identified preoperatively. So there's a bit of handover work that needs to happen, and a guideline can be useful for that. So that red, amber, green image has been really useful in that there's steps within that we should apply to all patients that kind of have screened positive, or perhaps all patients that are heading towards the kind of, you know, elderly stages of their life. Whereas if they're a case that's been identified as being very high risk, but after shared decision making, they've decided to go ahead, then you're wanting to apply everything in that red section. So you're into your kind of BIS monitoring, very strict focus on drugs to avoid, trying to be really clever about your analgesia bundle, so to avoid delirium in the post-operative period. And then the post-operative bit, it's about communicating with your post-operative teams. You know, this patient has come into your ward, they've been identified as being really high risk for kind of frailty-related outcomes. The anaesthetist has done what they can, the team have done what they can intraoperatively. Can you please monitor this patient really closely? Can you get, ideally you would have a care of the elderly physician or a ANP coming to see the patient every day alongside the surgeons to kind of give their input. But if you don't have that, then can you have the nursing team doing a daily 4AT to pick up delirium as soon as it happens, and use that kind of care bundle approach to delirium that most hospitals have in place, just increasing awareness again of that.
Great, thank you so much, Laura. There's lots of other questions in the chat there as well, but we're running out of time, I think. But just to kind of a little pointer for people, there's been a few questions about how do we get started and how do we get access to business plans. We have the NHS Elect POPs network, which has been established to support units setting up their services or support those who are expanding their services and need some advice on how to do that. So probably the easiest answer to that question at the minute is to drop me an email through CPOC, and I can get back to you about that with some more pointers. But it really kind of just remains to me to say thank you so much to both Laura and Peter, illustrating kind of how we can do this, and it just needs us to rise to the challenge of it, but also to use all the shared resources that exist around all four of our nations to be able to progress this further. So thank you very much, Laura and Peter. That was a great session.
Thank you.
Thank you.
So good morning, everyone, and thank you to Laura and Peter for that. It was really informative and interesting discussions. So my name is Steve Evans. I am the current CPOC Fellow. I started in August of 2021, and I'm delighted to be chairing this next session on multidisciplinary team meeting. We've got some really interesting speakers coming up with Emma McCone. We've got Will Ricketts, Ching Pang, and Thomas Bishop. So first up, we've got Emma McCone, who is the nurse lead for preoperative assessment at Newcastle upon Tyne NHS Trust. And Emma will be speaking to us this morning on training and education of perioperative teams. We're very much looking forward to this. Emma, over to you.
Morning, just a quick sound check. Can everyone hear me all right?
Yes, we can hear you, Emma.
Lovely. I'm just going to share the screen then, and then I'll make a start. Okay, so hello everyone, thank you very much for inviting me over to speak at the CPOC Leeds meeting. My name's Emma McCone and I am the nurse lead for preoperative assessment at Newcastle Trust. I've been the lead nurse since 2005, so I've been there a long time. I've currently just spent the last year in vaccination, which has been fantastic to help look at obviously vaccination in the nation, in the region, and it's been fantastic, and I think will really help my pre-op work as well. So today's talk, obviously we've only got 15 minutes and I've got quite a few slides to get through. Just want to give you a quick overview of, from a nursing perspective, about pre-op assessment, understanding the issues at nurse or DP level, why sometimes when we're looking at the basics that can be quite hard for staff. It's quite confusing with all of the new guidelines coming out, especially after COVID. And then I just wanted to spend a little bit of time on talking about something that we've done in the region called CPOC, which is the training and education of perioperative teams. So obviously we know the issues that are happening. We know that obviously there's a huge focus on surgical waiting lists. We've got lots of patients waiting for surgery, lots of patients waiting for diagnostics, and there's been a real push lately to get as many people assessed and optimised for surgery. And you know, I've picked these couple of headlines out. Some of the papers do overdo things sometimes, but we know we're in a bit of a crisis where waiting lists stand. There's some amazing bodies out there, CPOC being one of them and the Royal College being another, the RCN around perioperative care. And for me, when I look at the gold standard of what these bodies suggest, how we streamline services and how we build our services around perioperative care, I've picked out just a couple of things there. The majority of patients will require face-to-face nurse-led consultation. We know now that we're moving to I can never say it. We know we're moving digitised for a lot of our work, phone calls. We're very much still working around NICE guidance, which for me, I'm going to put it out there and say I find it very difficult to understand as a lead nurse. And I know it's quite confusing for a lot of nurses on how we manage our protocols within pre-assessment. And obviously from the Royal College as well, there's a couple of things I've picked out. So all about that we need to have adequate time to assess these patients. And it was interesting listening to a couple of the talks earlier on that we've got so many different things now to assess patients for, including frailty. We're looking at optimising comorbid disease, shared decision making, all of these things that we've learned a lot about as time has gone on. But obviously it's still looking back to the basics of what pre-assessment is about. And I think for all of us, we have to look at our regional data. We've got to look at our local patients and how that surgical mix is, away from a region with quite high levels of social deprivation. And there's a huge focus now on health inequalities, and that's something I've seen more at vaccination. Obviously, there's huge push on us now looking at behavioural change and how we optimise these patients for surgery. And there's a lot of risk scoring coming into our workload now around clinical frailty scoring, behaviour advice, lifestyle advice, educating patients around weight. All kinds of things is falling back into the pre-assessment clinics. But the reality of it out there, and I think this is a really powerful slide for me, I'm on a WhatsApp group with a number of preoperative leads and nurses across the whole of the UK. And some of the things that they say on this app is all the same. Pre-op's like a tsunami right now. We're so behind with the pandemic that we're so short of slots. Pre-op is mind-blowing. I feel like jumping ship because the workload's just got too much. And I appreciate, as all healthcare professionals, we probably all feel like this right now. But I think from a pre-op point of view, this is how the nurses feel in the pre-assessment clinics. And I think sometimes we get an unclear message from leadership at times that we need to work harder, that we need to do more, we need to increase capacity, we need to find more slots for patients who've been long waiters, who are going to breach these dates. And I think the guidance is see more patients in less slots, but for that we really need an effective triage system. We know that many patients are sicker. Comorbidities are less controlled. There's a huge issue around mental health suffering, especially after the pandemic, social circumstances, and as I mentioned before, social deprivation. And we know that across the board, there's tired staff across all the sectors. So for me, it's very much about redesigning pathways and how we look at our preoperative workload. This is meant to be just very light-hearted humour, but with anaesthetists, you hear the same stories from the pre-op nurses or DPs all the time. There's a lot of variation in a lot of clinics, and I always put these in. It normally gets people just to have a little giggle to think about what kind of anaesthetist they are. So we've got the anaesthetists who, you know, pre-opt and reviewed somebody and they're happy, somebody who wants to, you know, look at everything from every angle, and then we've got, you know, yes, I'm happy with this. And I think when you listen to the nurses' stories across the UK, they find that variation very hard sometimes, and it doesn't help when we try and streamline how they do pre-op assessment. So I just wanted to share with you a quick case study, something that I asked nurses all across the country. 56-year-old woman presents for hysterectomy for fibroids, BMI 28, controlled hypertension on metoprolol, previous smoker, no recent respiratory infections, and recently diagnosed with diabetes with a HbA1c of 91. And I asked a very simple question based on ASA grading and the NICE guidance, which is very much about how we grade our patients. And I think a lot of the tools that we use are based on this ASA grade, which I'll be honest, I find very, very difficult. I think it's about looking at the patient, the comorbidities, and how controlled or uncontrolled that is. So I didn't just ask the nurses, I asked a group of anaesthetists from the Royal College event, and we got a very similar split to this next slide. So this was 44 nurses. There was somebody who said they were in ASA grade 1, but then it was a real split between ASA grade 2 and 3. And then I asked them, for this type of patient, what would be your pre-op testing that you would do in terms of any investigations? And you can see there again the variation, 41 for full blood count. LFTs was 21 staff would have done an LFT, some would have done lung function, nearly everybody would have done an ECG and an HbA1c, and then there was a couple of clotting screens in there. And then I went on to ask them, well, what would you do? What would you do with this patient? Just looking at the history, looking at the ASA grade, what would be your next course of action? And again, from the nurse's perspective, many would refer to the anaesthetist, some would also refer back to the surgeon, and then there was a proportion of staff who would refer back to the GP. And I think there was no right and wrong about how units worked and what they did, but what became very apparent when I was talking to these nurses and doing some training around this was actually they didn't really know what to do. And even when you look at the NICE guidance, I think sometimes when we look at that, we struggle with, well, is it major surgery? Is it intermediate surgery? How would you classify it? ASA grade 2 is diabetes, but 3 is also diabetes. And we know that this person has uncontrolled diabetes with such a high HbA1c, but the targeted testing still is very subjective. And I think you can really see across all of these nurses who came from lots of different sites, it was very much about variation. And when we looked into it a little bit more and I chatted about variation, what do the nurses say? And you get the same comments all the time. I just do everything because if they get cancelled, it'll be our fault. And I think that happens a lot. There's a real fear that if we don't test and do every test, that if a test hasn't been done, that can potentially result in a cancellation, which is the worst thing for the patient and the staff. Some people said they've always done it that way, so there wasn't really any initiation of change. Yes, we've got set protocols, but actually we don't really understand the protocols and the guidance that well. People use their own initiative based on what they know or what they've always done or what they've learned from their previous colleague. Many hadn't done any formal training around what preoperative assessment is, and many haven't seen the guidance, and I know it's well publicised out there, but I think sometimes a lot of the guidance is still very directed at a medical level. And then there's lots of nurses who were trying to recruit into preoperative assessment, ODPs as well, which we have quite a few ODPs in our unit. they struggle to understand it because they come in and it's like, well, we do this for this, this for this, and it's a huge workload of understanding what it is without the easy protocols. So I think, how can we make it better? I think it is about looking at the regional population before we make decisions on set resources and protocols. I think we've got to look at cancellation rates. Why are people being cancelled? Is it for something that we could have done at pre-op assessment? I think everybody will agree that low risk pathways and high risk pathways are the place to go now, so that we can concentrate on shared decision making for high risk, making sure that we're doing the right investigations and having the right chat with patients. But we need not to forget all the patients who are coming in low risk, and making sure that the nurses feel happy and competent to look at bloods and ECGs. And we need the right staff doing the right type of pre-op. So I'm a strong believer in upskilling our workforce and making sure that our unqualified group resources, our nursing associates, have competency frameworks that they can work in to assess the low risk group. And what should the pathway be, or what could it look like? And I've just popped a brief slide up about what low risk surgery is. Can it be digitalised? I know a lot of people are talking about that now, but we need to make sure that when it is digitalised, one, we don't create an inequality and patients can do it. And two, that triage needs to be really set right so that the right people are seeing the right patients. And then it gives us a chance to look at our high risk, elderly, frail patients who probably need much more of an intervention and input from us. And part of that work in training is what we share among our regional meetings. So we developed CPOC, which is Training and Education of Perioperative Teams, which is something that all of the hospitals across the North East and Cumbria are invited to. It's a place where we can share ideas. And I think the idea very much came from a visit to EPCOM that I had a few years ago, where they really advocated perioperative regional meetings. And we came up with the idea of teapot, so we would get everybody together. And I think we do lots of good things, and we love tea. So it was very much a focus on, let's get together over a cup of tea, make it quite an informal meeting. So this isn't something that's formalised. This is about creating good ideas over discussion. And I think in perioperative medicine, it's really important that we recognise this is an absolutely multidisciplinary approach. So everybody's invited to this meeting across a wide range of disciplines. It's about sharing our good practice. It's about ensuring that we've got standardised protocols across the region if we can have them. It's looking at key messages that we get from our national bodies like CPOC, like the Royal College, and looking at how we can embed processes within our practice. And it's very much something that has grown. It was harder during the pandemic because we had to divert teams and everyone was obviously extremely busy. But the last meeting we had before the pandemic was a meeting of 85 people across the region who came together for an in-house conference where we looked at lots of great things. And it, like I said, it's open to everybody. It's open to surgeons, anaesthetists, nurses, healthcares, AHPs, pharmacists, and share from clinical perspectives what can help shape the future. Quarterly meetings with different agenda items where we look at an area of excellence within one of the hospitals. It can be enhanced recovery, pain, research, and then an educational session where we can share some good practice and training. And that was just our initial teapot meeting, where there was just 5 of us from different trusts, where we tried to find out what the structure should be. And then obviously that was another meeting that we had that was supported by the Royal College and accredited for CPD points, where again we got together. So it's become a really nice thing to share in the North East. We've had some great outcomes from this. So we've got regional anemia projects that were underway. We got together during COVID to look at how we would use CPET as an aerosol generating procedure and put some guidance and practice into that, which we shared across all of the hospitals using CPET. There's an AI project going on for looking at predicting risk factors, which everybody's involved in. And I think more importantly, it's about the PAC leads being in touch. It's a forum for questions. We can share things. We can chat and email each other and have you got a protocol for this? Have you got a protocol for that? And for me, I think it's really encouraged positivity within our region. So I can't manage, I've done this in time, which has shocked me because I think I had 23 slides in. But my end thoughts, and I know that was quite a whistle stop tour about education and training, but I think COVID for me as a peri-op lead nurse has brought to the forefront that we've got huge things that we need to consider within pre-assessment, especially because that's my huge area that will help the pre-operative pathways continue. I think we have to get some investment into training nurses, because if we want to recruit, and I think it is such a fascinating speciality, peri-op medicine. I've just completed my master's. I found it hugely empowering as a nurse, and I think it's really important that we want to recruit in this area, because I think you learn so much. I think we need to start thinking outside the box, and if those low-risk pathways are going to be digital, we need to think about how that's going to work clinically. I think regional networking is key. National networking is great, but sometimes being in the region and closer together it is fab. And I think nurses do want to be involved more, and I've been delighted to be able to just share some thoughts with you today and being an advocate for the nursing ODP AHP teams. But I think it is about getting back to basics. And that's it, I'm done.
Thank you very much, Emma. That was a very interesting and very informative talk. So what we'll do, we'll move on to the next session, and then we'll come back and we'll do a Q&A at the end. So could you please post any questions in the Q&A box, and I'll collate them all and we'll talk about it at the end. Thank you, Emma. So continuing on the theme of multidisciplinary team working, we have got Dr. Ching Pang and Dr. Will Ricketts, and I also gather that Dr. Thomas Bishop might be joining us at the end, if I'm not mistaken. So Dr. Ching Pang, thank you very much, is a consultant anaesthetist and a perioperative medicine physician at the Royal London Hospital, and Dr. Will Ricketts is a consultant chest physician at Barts NHS Trust. So thank you both, and over to you.
That's perfect. Thank you very much. I'm going to start sharing my screen. The one thing that I haven't quite worked out is if I start sharing my PowerPoint in presenter view, whether you'll be able to see my notes, but let's try that. So can I just check that you can hear me and that you're seeing my slides rather than the entirety of it?
I can hear you, but unfortunately we can see your next slides and we can see your notes.
Don't worry, I have an alternative.
Oh, there you go. That's done now.
We'll do it this way. So good morning, everyone. Thank you very much to CPOC for the opportunity to speak to all of you today. As Steve has said, my name's Ching and I'm a consultant anaesthetist at the Royal London. And I'm giving this talk along with Dr. Ricketts, who is a chest physician, and Dr. Bishop, who is my co-lead. For context, here at the Royal London Hospital in the last sort of 12 to 24 months, we've undergone quite a significant overhaul of our perioperative multidisciplinary team process. And that's what we've been invited to speak about today. So I'm hoping to spend the next 10 minutes covering the following objectives. I'd like to tell you a little bit about our structure and our process and how we arrived there. I'll tell you a little bit about who comes to the MDT and how we ensure attendance as well as quoracy. I think probably the best way of illustrating how helpful it's been to us as a team, not just within anaesthesia, but as part of a wider team, is to use a couple of case studies. So we'll be going through those. And finally, I do have a little bit of data on our outcomes that I'll be going through with you. The first thing to say probably is that Tom and I are both absolutely sick of the word iterative, but it is really, I cannot emphasize the iterative nature of the development of this MDT process enough. We started with some really helpful insight and guidance from our Trust MDT guidance that was very helpfully actually written by Will. And we came up with a vision of what we sort of wanted for our own MDT. We knew it had to be pretty simple and straightforward because we don't have a huge amount of administrative support, and we knew that we needed to be fairly inclusive in terms of the modalities, as well as how we sort of collected referrals and sort of encourage wider participation. So we have got an electronic referral form, which you'll see in a minute. We've got a set time, which is 2 hours on Wednesday afternoons. And the key for us has really been ensuring that there are dedicated people who are job planned to attend this. And we'll go through this slightly later on. But at least one of myself or Tom as a dedicated chairperson will attend the meeting in person. We make allowances for both virtual attendance as well as in-person attendance within our seminar rooms in the department. And we have a fairly, I'd say it's structured, but it's a loose structure. So we aim for no more than 20 minutes of discussion per patient, accepting that some patients might be complex and take more than that, and some patients might be quite straightforward and take less than that. And we aim to upload outcomes to the electronic patient record within 24 hours of discussion. So here is an example of our current Periop MDT referral form. You'll see that it actually will also double up as an outcome form. Quite important for us because actually it means that half of the work is done by our colleagues who are making the referral in the first place. We've also found that it really helps the referring clinician to engage with the key issues that are pertinent to the MDT, as well as the relevant questions that they have for the MDT. This is the second half of the form, which is filled in real time, generally during our meeting. It looks at the specific inputs from the various physicians that we have job planned to attend, and it also has our specific patient-related outcome, whether that's proceed, delay, or not offer surgery, any further interventions or optimization routes that might be applicable, as well as a recommendation for post-operative care destination. This is a very early version of one of our MDTs, just when we started it. And as you can see, everyone was more or less at, well, actually half the people in this photo at home and half the people in this photo are at work. And you can, there have been many negative impacts of COVID on the way we work, but one of the positive impacts is the real drive to have virtual attendance at meetings and the associated investment in audiovisual equipment that's brought. So we've really been able to guarantee sort of good attendance because we've got a good AV setup now where we didn't before, because people are much more familiar with using Teams, because we are able to screen share and not have the computer crash. So that's been really one of the key things. And in terms of who actually attends our MDTs, so from team anesthesia, we have a minimum number of 3 consultants to ensure quality and robustness of decision making, because either myself or Tom is job planned and there are a couple of other people job planned, we generally achieve this with no problems. We do expect the referring consultant to attend wherever possible for the discussion of their patient. And then from the physician's perspective, we have 3 physicians job planned into a regular attendance as well. And again, for quality, we've mandated that a minimum number of 2 of them attend each meeting. Our matron, as well as any nursing observers that she wants to bring, are in regular attendance, and we send out ahead of time an invite to specific surgical teams or surgical consultants where it's appropriate or relevant. I think for me, really, the best way of illustrating the value of the MDT and how it's really enhanced our processes and our care for our patients is to go through these case studies. And so I'd like to start with a case of mine. Sorry, I've already mentioned earlier that we have a set list of referral criteria to the MDT. So amongst these, we would include anybody whose risk is deemed to be either in excess of 10% mortality or high, excessively high for the procedure being proposed. Another referral criteria would be a patient who's declined surgery on the back of a conversation with either a member of the clinical team or one of the consultant anaesthetists. And another very common referral criteria that's used is questions about nuances in decision making or difficulties about routes of optimization. So I saw this lady who's 78, who had a diagnosed bowel cancer and who was proposed for a laparoscopic right-sided hemicolectomy. I don't expect you to read all of this, but it is very, very clear that she actually had very significant respiratory disease, which didn't just include severe COPD, but also included a pneumonectomy for lung cancer. She had not insignificant coronary artery disease, as well as other cardiac disease. And she was evidently very, very frail. Her possum mortality and her sort mortality, which you can see there, were perhaps in keeping with what you would expect. And essentially, I think this isn't necessarily a case where the decision-making itself is potentially going to be either difficult or controversial, but I've used this case to highlight the way in which I feel the MDT has really helped enhance the robustness of that decision-making, but also the holistic manner of care for this patient. So because this lady came to my clinic about 6 months after we'd started the process, I was able to use some of the tips and the techniques that we discussed previously in order to help with the communication of risk to her and her daughter, using sort of methods from the Choosing Wisely campaign. We talked about advanced care planning and her wishes in the context of either having surgery or not having surgery. And we also were able to talk about disease-specific prognostication, not just from her cancer, which is perhaps what we would traditionally have talked about using a sort of BRAN model of shared decision-making, but also talking and thinking about her COPD. And I used a scoring system that we'd learned from Will, that we talked about its validity of, and I was able to have that initial discussion with her in clinic before I ever even brought her to the MDT. As it happened, she declined surgery off the back of our discussion. And because of this and because of her estimated perioperative mortality, I brought her to the MDT. We discussed everything as we normally would. And here you can see the filled out pro forma where we look at each of the systems individually. We think about optimization strategies, anything that might possibly materially impact the risk, and then we put it all together. And in the case of this lady, it's not unsurprising that perhaps that there wasn't any specific thing that we could have done to mitigate her risk. But we were able to say as a team that we supported her in her decision, that we agreed that the estimates were correct. And more importantly, though, we made a recommendation which was then carried out to engage with advanced care planning in the community according to the gold standard framework. And she was engaged then with the palliative care team as well as her community practitioner. The outcome for this lady actually was that she was admitted to hospital about a month and a half after she saw me in clinic with an infective exacerbation of COPD. And she unfortunately passed away. But because of the planning that had been put in place, she was able to vocalize her needs and her desires. And she actually died in a hospice with a sort of rapid discharge and a turnaround from A&E. So the other way in which the MDT has great value to us is by helping us optimize patients for surgery. I've just shown you a case of a patient who wasn't able to be optimized for surgery, but this is someone who presented for surgery. And we know that our patients come for complex major surgery, but they also have complex comorbidities. And in addition to this, the way we do our assessment in pre-assessment clinic quite often picks up additional previously undiagnosed comorbidities. So that might include undiagnosed cognitive impairment, undiagnosed obstructive airway disease, or even issues with sort of social circumstances. The value in the MDT is that we have a round robin assessment between all of the various specialties in medicine, whereby we are able to gather information not just on their current status, but also on the likely natural progression of their disease states, whichever one it is that is most relevant. And we're able to make recommendations ahead of time to either optimize patients, to investigate them further, or to make plans for their perioperative care, including up to discharge. We invite our surgeons to talk about alternative options for oncological management. And as anaesthetists, we think about other objective methods of risk stratification, which would include CPET. And we also think about perioperative anaesthetic technique as well as postoperative monitoring. Hopefully, this helps us to mitigate some of those red flags that get raised ahead of time, and in so doing, sort of smooth out that perioperative course for the patient. I'm going to finish now with a very brief touch on our outcomes, and this comes from our database of the patients that we've discussed over the last year. You can see from the referral form that quite a lot of patients have significant medical input or physician input, and just over half our patients have a combination of at least 2 or 3 inputs from our physicians. So whether that's a titration of their inhaler therapy and a comprehensive geriatric assessment, or cardiology input in terms of recommending additional stress testing along with cardiopulmonary exercise testing. We do occasionally engage with the other specialties as well where it's important. So renal would be our sort of 4th biggest medical specialty, along with hematology and endocrine. And of the patients that we discussed in the MDT last year, just under 40% had a change to their initial surgical plan. Most often, so in about half of that percentage again, this was a delay to surgery pending optimization, and the surgery then went ahead. But the rest of the time, the surgical or oncological management was changed to a less invasive option. So an example of this would be endovascular work rather than an open AAA repair, or chemoradiotherapy in the context of endometrial cancer instead of a laparotomy and a hysterectomy. I can't sort of finish this off without touching on the sort of non-clinical professional benefits that the MDT's really brought to us. I think it's made our shared decision-making incredibly robust. It's now a true sort of team decision with the patient at the center of that care, and it's clearly documented in letters as well as in our outcome forms. It's provided us with a fantastic structure for education, but also governance as well. And it's really enhanced the sort of multidisciplinary nature of how we work down in pre-assessment. It goes without saying that we've built this fantastic network, and you'll be hearing from Will in a minute, of physicians who are interested in perioperative care, who are always willing to give us a hand whenever we've got a patient who looks slightly dodgy in clinic. But actually what it's also helped us do is engage with the allied health professionals within the hospital who have an interest in this as well, whether that's the nurses on the hematology unit or the sort of therapists who look after our patients postoperatively on critical care. So that's been a whistle-stop tour through the setup of our MDT as well as some of our outcomes and the sort of perceived benefits from us. I would say that there are lots and lots of questions, I'm sure. Tom and I will be both around in the discussion, but I'd like to just hand it over to Will, who's taking the last, hopefully, 5 minutes of this slot.
Can you hear me?
Yeah, Will, you're going to have to tell me when you want to move forward.
I was going to say, actually, I'm going to share my screen. It's probably easier.
Okay, cool. I'll stop sharing.
Which hopefully is that one, and hopefully we'll now move forward. Excellent. So why am I here? Why is a chest physician speaking at a anaesthetic meeting? Good question. And my slide hasn't moved forward. Right, there we go. So I was appointed at Barts Health as our lung cancer lead, and I'm actually in the middle of my lung cancer clinic at the moment. I've had to take a bit of a gap between patients for this. And when I was appointed, one of the first things I noticed was that for a cardiothoracic centre, we had a remarkably low lung cancer resection rate. And for us, resection rate is king. That's our #1 outcome measure that we get sort of compared to other centres on. So I did the right thing. I audited it, I looked at the issues, and actually cardiorespiratory comorbidities were our biggest single reason for potentially resectable patients not having lung cancer resections. And this got me interested in the concept of prehab. And as you can see, as part of that wider process, our resection rates have now moved from almost statistically significantly below the national average to now, for I think the 2nd or 3rd year in a row, having the highest resection rate in the UK. that's not what today is about. But if you do want to read more about it, you can here. But that's how I got interested. And it's a shame that I haven't been able to make the whole session, because I'd have been really interested to hear Peter's talk earlier about the perioperative physician, because we are an oddity, we're a new breed, we don't exist, there's no training for us. So I've had to train myself. So I have been to anaesthetic conferences, I've been to CPEC courses, I've been to an anaesthetic CPEC course, I've been to a respiratory CPEC course, I've been to a physiologist-led CPEC course, and so on, and you end up effectively becoming self-trained. So that's my background, and that's how I got interested, and that's why I'm here. What do I do? So I talk about these three pillars. So the three reasons that patients tend to be referred to me for an opinion. So almost always it's clarifying or confirming a diagnosis. So maybe they've had abnormal spirometry in the pre-op assessment clinic, or they say they've got a respiratory diagnosis, but it's not clear what. Then risk assessment, so what impact does this respiratory diagnosis have on their proposed upcoming surgery or other treatment? And is there anything we can do to optimize them to reduce that risk? And this isn't always a linear process, so and not all patients need all three pillars, but those are the broad areas that I tend to work in with the MDT and the patients that we discuss and I see. As part of this, so partly to streamline it, but partly to get the right patients under my nose, we've started to produce a couple of pathways, and these are, so the one on the left, our spirometry or COPD asthma pathway, is pretty well established now. The one on the right, potential OSA pathway, is still in a sort of pilot phase, but these are to try and flag the right patients early. And so what have we done with this? So is this a good thing? Would I recommend this to all of you? So literally as of Monday, this got published in the Future Healthcare Journal. So this is our piece on the initial spirometry work. And again, not going to go through it all, and you can read it at your leisure. It's not a particularly long piece. But what did we find? So we found that 183 patients underwent spirometry as part of our protocol or part of our flow diagram, of which 70 had airflow obstruction, and in 25 of that 70, they did not have a previously known respiratory diagnosis. So we've picked up undiagnosed respiratory disease preoperatively, rather than waiting for it to cause complications post-operatively. Similarly, even of the patients with a known respiratory diagnosis, simply looking at the COPD cohort, nearly half were not on optimal therapy. So we've picked up a chunk who didn't have a known diagnosis at all, and another chunk who had a known diagnosis but were not on optimal therapy. And that has given us the opportunity to both risk assess, but also intervene to reduce that risk, so optimize their care to reduce that risk. We've also picked up obstructive airway disease in never smokers, so we assume that these are new diagnoses of asthma as well. And again, that's given us the opportunity to intervene and optimize pre-operative. So where do we take this forward? So this very much fits into my three pillars principle. But A, it's allowed us to make the diagnoses. B, it's allowed us to optimize these patients. And C, it's allowed us to undertake shared decision-making with these patients, as we all know that we should now be doing. I think we're having questions and discussion as a Q&A after, but I'm aware this is a very short talk, and anyone that wants to engage on social media to have a wider discussion, you're really, really welcome to, although I won't be answering any questions till after my clinic at least 1:30, but I think we're going into the Q&A now.
Thank you, Will, for that presentation. Thank you to Ching, and thank you to Emma. So I just want to pull together just some questions, really. So I mean, there's obviously lots of similarities that we've been talking about in this session, which pulls together with the previous session, with namely with Peter Robinson setting up, the frailty service down in the southwest, and just wanted to touch upon just some of the comments, really, just pulling together some themes. So one was about assessment and how to assess some of these patients. And on one hand, there's a comment about why aren't we doing more for virtual assessments, particularly for the lower risk patients. And then there's another comment about how you can't really do virtual assessments for some of the higher risk patients because you want to see the patients, you want to assess them, see how they are on the bike, for example, or do an examination. So I just wanted to maybe bring in Ching, for example, and say, with your MDT working, how did you feel about this balance between virtual and face-to-face?
Tom, feel free to chime in.
Yeah, sure.
I feel like our balance is actually quite different to perhaps quite a lot of centres.
Yeah, I think we at the Royal London do far more high risk, major complex work than our other sites within our trust. I think you're absolutely right. You need to stream those workflows. I think the key to that is actually going back to what Emma's talking about, which is essentially that the nursing assessment or the initial assessment, however that's made, is absolutely foundational in how you then stream them. But also, a chunk of that high risk work will not need complex medical input necessarily, but you'll only know that if you've done all of the assessment beforehand. So one of the things that we've done at the Royal London, particularly triggered and driven by the COVID pandemic, has been to bring a slew of things that we previously outsourced into our department. So we perform, or rather the nurses perform, all of the spirometry for us, and we stream that based on surgical type or complexity, or if it's triggered by a nursing assessment of their fitness. So a chunk of this is about how you use that first assessment to stream your workload.
And Emma, from a nursing background, how do you feel about virtual or face-to-face?
So it's interesting. I think when digital's come along, and it's come along quite fast-paced, we're electronic in our trust, but it's not patient self-assessment. We do it digital. I've seen a lot of the digital platforms, and I think there's absolutely an area for them, but I think it is about, when these digital platforms happen, picking the right patients to do them. And I think we have to look at social inequalities and how people can fill these digital assessments in. The questioning's got to be right, looking at health literacy. Sometimes it's the triage process that makes it more difficult. So when they've completed, the nurse is almost going to do it all again, and then they're basing it on an ASA grade risk score. And if those aren't set up correctly, I've seen one lot of data from one of the digital companies where half of the ASA grade 1 and 2 still came back to a face-to-face clinic. So I think it's about improvement, isn't it? Service improvement, how we get that right. I'm not averse to it. I just think it's got to be done regionally focused, patient focused on the right patients. And then it's about what we do with it. I believe more in upskilling the workforce, that we use maybe, qualified nurses in the more high risk patients and maybe unqualified nurses in low risk pathways, because ultimately some of these have got to still pop back for a blood test, or they've got to pop back for an ECG, depending on what they've got wrong with them. So I think using competency frameworks along the healthcare staff, the nurse and associate staff, is got two big positivities. One, we're upskilling the workforce, and two, it gives us a more diverse workforce to work from when nursing is really short.
And as we're in this slightly kind of bumpy transition at the moment between COVID and not quite obviously out of it yet, team working and tackling the elective surgery backlog is obviously extremely crucial, and working together and breaking down barriers and not working in silos is absolutely key. Just coming back to Ching and Will, and I noticed on your MDT working, obviously you've got a team of people. You mentioned cardiologists, and obviously you've got Will, who are obviously very single organ focused, maybe the heart or maybe the chest. Just wondering what relationships you have with some of your elderly care physicians and some of your wider colleagues who may have a bit more of a holistic approach.
I think Peter might remember, as he used to attend some of our MDTs, but we've got a well-established relationship with our geriatricians, who have immeasurably broadened the scope of decision making and interventions that we offer as anaesthetists. I never thought I'd be talking about end of life care at the start of an anaesthetic assessment, but once you can identify them and look at patients in a holistic way, which is what our geriatricians have certainly brought to our service, the world's your oyster. In terms of our other specialties that are invited or involved, we've got who's PA'd into supporting our service. Well, we've got the cardiologist PA'd in, we've got Will and some of the respiratory team PA'd in, we've got geriatricians PA'd in, and we've got some renal physicians PA'd in. So that covers the broad base of the common medical specialties that we need to access, and then we often have go-to people within other services who have helped us write guidelines in the past, who we tap into when we have a specific question about, I don't know, hematology or things like that. But the key to all of this is collaborative working, and it's not something that happens overnight. This has happened over a long period of time, and it is all about pressing flesh and having conversations and building those relationships.
And I was really glad to see that you've also got allied health professionals on your team as well, particularly nursing staff or physiotherapists, occupational therapy, and that's really important as we go forward with perioperative care and pathways to involve allied health professionals. And just coming on another theme about education and training, Emma, you've spoken a little bit about it. I was just wondering what you felt were some of the barriers to your training. That's either qualifications which you've gained, and how you felt the trust may have supported you in pursuing those qualifications to work within a perioperative setting.
I mean, I've been lucky because I was allowed to do my master's in perioperative medicine, but I know that I was only one of very few nurses on that course run by UCL, and it was hard and it was quite medically focused. But I think nurses do have CPD funding. It comes from the trust. They're entitled to money to support them with courses. The problem that we've got is I think it's about what we do in-house, and I think the leaders among the perioperative teams, whether that be the anaesthetic leads or the nursing leads, you need those induction packages in-house. A new nurse should be able to come to pre-op and have some formalised induction, just like you would do on a ward, but often they come into pre-op and it's just a questionnaire, or my biggest phrase is it's not just obs and swabs, because that's unfortunately the perception of what people think it is. And I think if we get that training right, then that helps people excel onto the further courses that they might want to do at postgrad level or degree level or even master's level. So I think it is very much about giving nurses opportunities to study and taking time out within our clinics to give them, that basic, because like all of you were saying, we're progressing perioperative medicine so far on that it's almost gone away with us from an optimization, shared decision making, high risk. It's fantastic work, but we sometimes forget the basics of what that work is based on. And it is about picking the right patient to go into these more MDT clinics. And if we don't get that right, then it often leads to failures and cancellations or upset patients who wanted a bit more.
Yeah, and it's really important to know that we as CPOC, on our website, we promote these courses, and there's links to advanced care practitioners, for example, and it's important to promote these amongst your wider colleagues at your institutions, to know that these courses and qualifications exist. So if they do want to pursue it, then there's a lot more information out there. Just a couple more minutes, and it comes down to a bit more about team working, really. And there's a question for Ching and team about the time pressures and how and the job planning from that as well. I mean, obviously the surgeons that list their patients, sometimes it might only be, a week or so, but sometimes you might have a bit more time. So how do you manage those time pressures within a multidisciplinary setting?
It's probably one of the biggest challenges that we face. I think we're constantly telling our surgeons that if they give us about 2 weeks, we can put virtually any patient through a process that will be robust and will hopefully lead to a decent decision-making process. It's really down to surgical engagement about how much time they allow us with the patients. So as in all trusts, there are good performing services who give us lots of lead time, and there are bad or less good performing services that don't allow us that. In terms of what I would say is that lots of the time pressures are often slightly artificial, in that I think what we have tried to do is, by making good decisions, that decision might be we stop the clock. We might pause things to get a patient better optimized or through a different treatment modality. I think in terms of how we mitigate against that, I think the pathways that work the best are the ones where, particularly in cancer work, where those MDTs, those cancer MDTs, very quickly feed into our pre-assessment booking system. So our gynae surgeons will have their MDT, I think it's on a Wednesday, and normally by Thursday morning we have a list of patients that need to go through our pre-assessment process. And by shortening the delays and getting the information to us, by giving us the most time with the patients, that's how all of us get the best out of this system.
I think the other thing, Tom, although I know the opinions on this are mixed, is that we, for some of the very time critical specialties, will triage into a one-stop clinic where patients are seen and they're warned beforehand that you need to bring your lunch, but they'll come in, they'll see a nurse, they'll see the consultant surgeon, they'll see the CNS, maybe the stoma nurse, and they'll see one of us, with then an anticipated lead time of between 1.5 to 2 weeks. Because those clinics are then worked around the surgical kind of availability, they then fit quite nicely. They dovetail with our MDT process. So we picked Wednesday because it's the day of the, it's the afternoon after the surgical MDTs. It happens after the one-stop clinics. And so we've tried to make those timelines as short as possible, bearing in mind the logistics in clinic.
Well, thank you all very much. We've come to the end of the session now. Emma, thank you very much for a very inspiring talk, and I'm really glad to hear that you're pushing the agenda from the nursing perspective and the allied health professionals. And it's great to see the work, Ching, Will and Thomas, that's happening at your institution as well. There's some very specific questions which have come through. So you can either type a response yourself or leave your email address for people to get in touch with you. But we are coming towards a 10-minute break. Louise and Alice, is it 11:15? You want everyone back?
Yes, please.
So thank you all very much. Less than 10 minutes, 11:15, and we'll be back online. Thank you very much.
Great, thank you. I hope you can hear me. Thanks very much for coming back. Apologies for it being such a short break, but we're just trying to keep to time. So I'm going to be chairing the next session on prehabilitation. And our first speaker today is Dr. Tessa Bailey, who's a consultant anaesthetist at Cardiff and Vale. And she's going to be talking about the prehabilitation service that she is running there. Thank you very much, Tessa.
Thank you for the introduction, Louise. I will start sharing my screen. Okay, Louise, could you confirm that you can see the slide correctly there?
Yeah, that's great.
Super. Good morning, everybody. My name is Tessa Bailey and I'm one of the consultants in Cardiff. And I was asked to talk today about how we set up our prehab service, the hurdles we faced and the practicalities of implementation. I'm well aware that many in the audience today have a great deal more experience than us, and some hospitals have well-established services whilst others are early on in developing theirs. I wasn't going to focus too much on what prehab is itself, therefore, but more on what happened as we went through this process. I'm also here to learn from you and share ideas, which we can do in the questions at the end, or I'm very happy to link up by email, so my email address is there. So a little bit about our hospital. As you can see from the map, Cardiff sits within the Cardiff and Vale University Health Board at the southern tip of Wales. And although geographically small, it's a densely populated area with 472,000 local residents, but we're also a tertiary referral centre, and so look after patients from mainly across the South Wales corridor, as well as West Wales, Mid and North Wales where appropriate. Pictured on the left is the Heath Hospital, or UHW, known locally. Very big hospital, 1,000 beds. At the moment really doesn't feel like enough, as probably the rest of you feel the same way. And then pictured on the right is the Cardiff and Vale Orthopaedic Centre, which is at Landock Hospital, which prior to the pandemic was doing all our orthopaedic work, spines. The breast care centre is there as well, and day case, major gynae, etc. It's important to understand your local population a little bit, and there are various ways of doing this, but by looking at indices of deprivation, we can see how this can become important, and health factors are one component of the overall index. You can see from the map that where there are darker areas, that denotes regions with greater percentage deprivation, and do indeed include the regions within our health board and around our health board that we look after. Last week for SNAP3, in the space of the 5 working days, there were 133 patients eligible for that. So those are those aged over 60, just to give a very recent snapshot, and we look forward to seeing the results of that for us. A few years ago, my colleague Richard Davis compiled a league table of anaerobic thresholds, and you can see that Cardiff is consistently across a few specialties quite close to the bottom of that. The pandemic didn't help us, and again from our CPET team there's some data from just prior to COVID in February 2020, and then once CPET was able to restart in August of that year, because we'd kept quite a lot of our major surgery going, you can see that the commonly used markers within CPECs have deteriorated, and indeed that a high proportion of the population fall into a higher risk category. And so on to how we began prehabilitation, and I'll show you a timeline. So in 2018-19, there's lots of meetings of the first sort of interested parties that began, and then a more formalised sort of stakeholder group. So that was initially our lead surgeon, who's a hepatobiliary surgeon, me, our Macmillan lead for therapies, and then our clinical lead for prehab to rehab, Rachel Barlow, who many of you will have heard speak about her primary care optimisation work. Rachel had secured recurrent funding from the then chief exec for a project that would span the whole patient pathway, hence the name Prehab to Rehab, and include all patients referred for cancer services in Cardiff, so all surgical specialties. The primary care element started in September 2020. We were then asked to submit our full business case to formalise it all by November 2020 for the rest of the project. Recruitment to the secondary care element followed, and in September 2021, 2 physios, 2 dietitians and an OT commenced work, with the first 3 specialties rolled out to colorectal, HPB and upper GI. The primary care element was led by Rachel Lee, who's a GP in one area of Cardiff, and they implemented an optimisation bundle which they developed with us, with common perioperative targets such as HbA1c and blood pressure in mind, and this is led by a senior pharmacist. Some of the hurdles they'd faced was the key rate limiting step, really, which is that the GP refers the patient into the service at the same time as making the cancer referral. That's manual at the moment, but they do hope to move to an automatic system, but depends on some coding issues. They've had some real struggles and ongoing, but hopefully soon solved, with information governance issues and the way that data is handled between primary and secondary care in Wales, which means that at the moment we can't pull through any information about those patients because the data is owned by primary care. Their model is being considered for managing the surgical backlog across Cardiff, which is great news as part of Spread and Scale initiative. And one example of this might be to include a mandatory field on electronic referral forms that the GPs make, so that triggers them to perhaps consider starting to optimise conditions at the time of referral. Business cases, I'm sure we've all been involved in those over the years, and there is a lot of work and you end up doing a lot that you never knew you needed to know about. One key question for this though is, what benefits are prehab going to show? We were all convinced from our learning from publications, presentations, meetings such as this and benchmarking, but we had to convince the others in our hospital. It's important to know your baseline and what you're going to improve, so you need to know what you're doing at the moment. And for us, we involved our informatics and also patient level costings team within finance quite early on. So what size team do you need, and what sort of team do you want to use, and what's the cohort of patient, how many are there? So we drilled down into individual specialties by looking at theatre activity or the cancer services data, and I won't go into the nitty gritty of that because it was several hours of my life that I won't get back. And it has actually come down to finding individual OPCS codes, just to be very, very careful that you're being accurate about what you're measuring and what you're then tracking going forward in order to show the benefits of prehab. And one thing that did happen to us is just round about the time it was all going to be rolled out, September last year, the outgoing chief exec then confirmed that he wanted the remit to be not only Cardiff residents, but also the tertiary referral patients as well. So that did sort of throw in a curveball as to the numbers, and I'll mention that again in a minute. And secondly, where will your data come from? So I don't know if your hospital keeps really brilliant, ready to go perioperative metrics, but ours sort of doesn't really. And do your surgeons collect their own data? Some of ours do, for example, upper GI and urology when the BOWS database was running. We have started with an ERAS database, which is on Excel at the moment, but hoping to move to REDCap. There are issues with Excel in how the data flows into the hospital business systems for them analysis and creating dashboards. So that's been a hurdle for us to get past. The therapies team did start using paper, and they're moving on to MS Forms. As they've done that quite quickly, and hoping to become more fully digital, because that does save their time as well. And I do wish that we'd included more resource for all of this on the data side of things in our budget. So a bit more on that. So having collected enough of it that we could then justify our business case, we did make some of the pledges that we thought we could do, such as decreasing length of stay by 2 days, decreasing post-op complications by 5 to 10% over 2 years, and important patient-centered markers with measures of satisfaction and experience and anxiety. But actually, over a year in, we're still learning how to do this better. And we're all familiar with some of the system metrics and the confounders there. So we have noticed that this can get tangled up in whether the patient is ready for discharge. Are there radiology investigations that are fixed within certain pathways? So upper GI need a barium swallow before going home, and similarly major head and neck cases will need scans before they go home, and that is at a fixed point in time. So that's useful to know. Also the day of the week of the list, and whether there's greater availability of the allied health professionals, including physios, on the ward. Critical care usage is really important to the system and to the hospital, but it's worth being careful that you separate, or you can easily separate out, planned time on PACU versus unscheduled level 3 bed usage. Readmissions for us can be tricky with our geography, because we need to be careful about whether they were readmitted to a different health board or whether it was an admission to a completely different specialty. And perioperative outcome metrics, a subject close to all of our hearts, I'm sure. This is not collected well at hospital level, and so we are using some of our surgeon-led data. We do have quite a lot of data from PQIP. We're very keen PQIPers here, and we've got some that's prospectively collected in the ERAS database, which is just 2 specialties at the moment. We've been doing that for a while, and that's driving local QI projects already. And actually, what we've realised is that sometimes it's good to choose something specific that matters to you and your surgeons, and therefore the patients. So, for example, post-op pulmonary complications in upper GI, and drilling down into perhaps a precise group such as Ivor Lewis esophagectomies rather than the transhiatals maybe, and separating them out from the partial gastrectomies rather than trying to prove that you've fixed something for the whole of upper GI when it may actually be a bit more nuanced. Time to adjuvant therapy is very pathway specific, but also very important. For example, head and neck majors need to continue to adjuvant therapy at 6 weeks, but if they're not well enough because they've had delays in the post-op period and not strong enough for it, then that gets taken off their treatment plan because the benefits just decrease at that time. And there's a similar thing for colorectal adjuvant therapy. Patient-centered metrics. This is something that I've learned quite a lot about. Actually, I didn't know much of this previously, and what seems to be quite marked is trying to be more specific about what it is you're measuring. And we have noticed already that the fatigue and anxiety markers do come down pretty well and improve with the input from our OT. The secondary care pathways, we designed having benchmarked with other centres and spoke to a few centres around the UK. In Wales, we have to adhere to the Welsh single cancer pathways, and so we need to be mindful of delays in the system. I drew up process maps with most of our surgeons and to find that Goldilocks moment for referral, so not too soon and not too late. And for the specialties we have at the moment, that's at point of suspicion. But for some coming in, so urology, for example, they don't want us to do that because it will be too many patients, and theirs is better at MDT. In planning those pathways, as I say, we've done some benchmarking. We do use the commonly quoted stratification of universal, targeted, and specialist. And so they were initially triaged by all 3 of the therapists, such as physio, OT, and dietitian. But this ended up being quite resource heavy. They're moving to more of an online system, which should help things. They'd noticed that about over 60% of patients needed to see the physio and dietitian anyway, so they do the triage at the same time, whereas the OT can quite well stratify her patients from the PROMs and H&A, which freed her up from triaging. And this is ever more important because we do have that capacity issue now that our remit includes the tertiary referral patients as well. And we also need to include our next specialties, so urology, head and neck, lung, and so on. They are trying to make better use of groups because that's more efficient. And one example is that there was low take up for the group OT. So they've moved that to it dovetails a bit better with the physical activity session in the gym, and also changed the time slightly of it so that doesn't coincide with when a primary school is having a swimming lesson just up the corridor. Pandemic, of course. The team moved on to a virtual platform really quickly in the last wave of Omicron, but unfortunately found that the virtual offer was not well received. Fortunately, that time period didn't last too long. It was getting better and they were finding some solutions. And also we went back to a 14-day isolation period, which didn't help things. So the secondary care therapies-led pathway, this is the revised version and shows that from the point of referral, where we'll be able to move the PROMs onto an online platform by sending an SMS link, will speed things up because a lot of the initial parts of the assessment can take place before they come in. And they have a key performance indicator of being able to see the patients within 5 days of referral. So they're trying to be as efficient as they can do. And then the joint physio and dietitian assessment, whether it's by the band 6 and 7s or by their support workers, can happen and is a bit more targeted on arrival. I won't go through the exact methodology they use. It's very similar to other centres. They refine the use of some things, for example, the EQ 5D5L instead of HADS and HUDAS, but those are used if triggered to do so. There isn't a finite length of time for our programme. They will keep patients involved if they're having NAC, if they can, and then see them prior to surgery for the final preparation and collection of outcomes. So here's some pictures. So on the left, that's Josh, actually, our Band 7 physio, standing next to the line, which is a thin piece of string, so you might not be able to see it very clearly. And that's where the patients got them down for the 6-minute walk test. And that is on site. That's in a building on site at UHW. And then the group exercise sessions are in Western Leisure Centre in Cardiff. And you can see a nice socially distanced space for the patients to do their group sessions there. And they do some one-to-ones there as well. So my final slide just takes us to where we are in 2022, which is in a position of evaluating the first 6 months of service with the therapies team, having seen around 250 patients from the 3 specialties. We do need to start looking at our data once we've got over some of the delays of that coming through, to be able to then plan what we do next. My comment about it being a hexagon, not a triangle, refers to the prehab shaped triangle, where, although it was probably never designed to be a true shape of universal versus targeted versus specialised, ours definitely isn't anyway. Physio is a sort of thin shaped hexagon, narrow bottomed hexagon. Dietetics is an hourglass, and OT is actually a bit more triangular. So in order to roll out to the other specialties, we need to look at different options because we've hit capacity quite soon. So not only efficiencies within the pathway, but expanding out to leisure and different methodologies perhaps. We also need to put some investment into the ERAS end of the pathway. We do ERAS here, but with more sort of locally driven initiatives rather than any ring-fenced resource. And there are some other posts that were funded within the business case, such as a diabetes nurse, pharmacist, and some physician time as well, that still need recruiting to, which is hopefully going to happen in the summer. So thank you very much, and I'll be happy to take questions in the question session after this. And my email address is there, and also Rachel Barlow's. We're very happy to keep in touch.
Thank you so much, Tessa. There's a huge amount of work you and your colleagues have put in there, and a great service that you've set up. And really appreciate you sharing it with us today. Our next speaker today is Tom Collier. Tom's a consultant in anaesthesia and intensive care at Harrogate District NHS Foundation Trust. And he's going to be talking about Active Against Cancer, which is his rehabilitation service there. Thank you, Tom.
Thank you very much, and thank you for inviting me to talk. Just check, can you all hear me and see the screen okay?
Yeah, all looks good. Okay,
so yeah, I'm Tom Collier. I'm a consultant in anaesthesia and intensive care, and I'm also the clinical lead for a service called Active Against Cancer, which I started writing the business case for in 2018, and we went first live in July 2019. So over the next sort of 15 minutes, I'm just going to talk about the background to why at the time we or I looked to set up such a service, how the model works, and a little bit about the some of the early outcomes we've seen. But I guess what I'm not going to talk about is the evidence base for prehabilitation, and nor also the evidence for exercise in cancer during cancer care, which is a fascinating area in itself. So the background, I'm sort of going to start, I think, as a group with a lot of anaesthetists present. I'm going to start with probably a very familiar story, and that is that, you know, I also cardiopulmonary exercise test patients, and in 2018 I saw a patient who I'd originally seen in 2015, who I'd exercise tested, who really the main thing showed to be extremely functionally low and very deconditioned in 2015. With a few modifiable risk factors, and as was a sort of a familiar story at that time, and the patient already had a date for surgery, it wasn't far away, and we identified her as being high risk and put packages of care in around that to manage that, but she was still going for her surgery, and the decision had been made. And as you can predict, she actually suffered with an anastomotic leak in the post-operative period. She ended up spending about 14 days in the intensive care, and she had a two-month stay in hospital. But the sadness for me was that I was seeing her again in 2018, and at which time she had a new primary bowel cancer on top of her original. In which case she was, as you can imagine, even more deconditioned and was deemed to be too high risk for surgery. And for me, there was just a whole sequence of missed opportunities. And at that time, we had just started recruiting to a national trial, which some of you may have also recruited to, the Prepare ABC. And there was interest in this period in this emerging science of prehabilitation. You know, could you take a patient within the preoperative period and alter their time course? And, you know, I was extremely interested in this. But I was also extremely interested in talking to the patients. From a patient perspective, that from the period from their diagnosis to their surgery is actually a very, very narrow window within the greater time period. And I wanted to have a more patient focused, I wanted to create a service which had a more patient focused area to it, particularly looking at rehabilitation as well. And actually driving to work, I heard about a service down in West Sussex, which was set up by a breast cancer survivor, in which she had converted her garage into a gym space for other patients in that area to be able to rehabilitate after cancer services, after their cancer treatment. And it got me to thinking around this area, if exercise is a pill and it could be prescribed to every cancer patient, was that actually possible within the NHS structure? And could I achieve something like that? So to go through the model, the active cancer model, what we've actually set up. So we have tried to have exercise and our service. We have tried to have exercise in our service as part of the cancer care pathway. So at the diagnosis, patients are referred by the CNS into our service, and it's opt out, not opt in. From discussions with patients, we wanted to be community based. We wanted to be in a community gym and set up a community gym just for patients with cancer. We wanted to be outside the hospital setting so that the patients had the opportunity to. Sorry, I'm just going to remove this. So the patient. Sorry. So we wanted to be set up within the community so that patients weren't coming to the hospital again. We wanted to have social support and inclusivity and fun as core elements of the service we were offering. So an overview of the service. Our aim was for patients to be referred in by the cancer nurse specialist at the time of diagnosis, straight to our service. We also had routes for referral for other healthcare professionals such as the GPs, the oncologists, anaesthetists. But we wanted patients to be picked up at the time of diagnosis and referred in. We aim to see the patients within 2 working days of that contact, and they're invited into the Active Against Cancer service to have a one-on-one assessment, and this is provided by a band 7 oncology trained physiotherapist, and we also have that provided by a physical trainer who's also a band 7. And at that point, they do a range of assessments, which Tessa's just described. And the patients are then given an individualized exercise program, which we then deliver within the community. The elements, our program is divided into 3 core elements. We have prehabilitation, a maintenance service, and rehabilitation. The prehabilitation, obviously, was within a finite period of time. We try to get patients as early as we can into that service. The maintenance provides a service for patients having chemoradiotherapy and those starting out on their hormone therapies to set them off on the correct path. And then rehabilitation is offered, normally within about 4 weeks of surgery. And patients spend overall about sort of 6 months within our service. And of course, our aim is to discharge patients to lifelong activity. And we have links with different other community services so that once discharged from our services, the patients aren't then lost for the activity, and they feel they have a safe discharge route out. To give you an idea of the classes we have on offer, we have a combination, not just of cardiopulmonary exercise, not just a combination of cardiovascular exercises, but also we have a focus on balance, flexibility, and core. But they're delivered again through fun classes such as yoga, Pilates, and we also have dance classes. We set up a walk and talk service to provide that sort of that lower level of psychological intervention. We have Tai Chi. And in fact, yesterday we have a group now, Friends of Active Against Cancer, patients who've since discharged from our service have set up their own social support. And they've, for example, got a water colour class being set up just next week. And this gives you just some pictures of the patients and the classes running and how it runs there. So obviously to achieve also the pillars of prehabilitation that we've already discussed, we have an educational program that runs as well. And we work closely with the other allied healthcare professionals. And it required some sort of cohesive working, because we've become really like the hub, the centre of the activities for a lot of the cancer care within Harrogate. So we now have the Macmillan dietitian who comes and does a monthly class with us, with our patients. And we also have a psychologist now who comes and does group-based psychological support sessions, covering different aspects of cancer care for our patients. So covering the different areas and integrating really the different cancer care supportive therapies. And we're also at a point where we've noticed that we're starting to pick up some of the more specialist areas. So we're able to offer scar therapy, we have a breathlessness clinic, and we can refer into some other services such as MSK, fatigue management. So to talk about some of the outcomes, my greatest fear when setting up this service was that we would put all this effort into having it, and then we wouldn't get the referrals coming in. And so this gives a run chart of the referrals we've had into the service since opening. You see we opened there in July 2019. We average about sort of 50-55 new cancer referrals referred into the service per month. And you can see how this has changed over time and the impact of the COVID pandemic. And actually, just to highlight here that the COVID pandemic didn't actually result in a drop in the referral rate. What we actually saw is less patients presenting to the hospital with new diagnoses of cancer. And this sort of leads into that secondary pandemic that's been widely talked about within the news of these undiagnosed or later presentations of cancer care. And of course, it's hard not to talk about the impact on outcomes without mentioning COVID. And I guess all I really wanted to say about that was we had sold our service, or we had presented our service to the other healthcare professionals and to the patients as being an integral part of the cancer care pathway, where we said that it was opt out, not opt in, and that it was as important as all the other aspects, including the chemotherapy, radiotherapy, and surgery. And of course, the COVID pandemic came along, and it told patients, rather than going out, exercise, be in control of your cancer care, to stay at home, isolate, and that you're vulnerable. So we had a real issue with sort of mixed messaging, which we had to deal with. But after the first wave, we did manage to remain open for face-to-face classes. And obviously we instituted a range of implementations to make sure that we're as COVID safe as possible. And also, as previously mentioned, we went to a virtual and home-based exercising as well, through a bank of telephone calls, online classes, videos, exercise guides, and daily challenges. This gives you an idea of, again, a monthly runtime of class attendance. You can see from August 20, well, we can see up to the pandemic that we were having approximately 100 patient attendances per month, 800 patient attendances per month within the service. And we now see approximately 1,000 patient attendances per month. So the service, for we are a relatively small district general hospital, that's a huge number of patients coming through. And this chart just shows you how frequently the members or patients use our service. And you can see that the median number of attendances is 2, with a range of between sort of up to 5. And again, some of those patients coming, they actually have no one else. And these were extremely isolated patients over the last 2 years, who found that being able to come to our service was the only form of social contact that they had. We did manage to achieve what we hoped to set out to achieve, and that is that to get patients at the point of diagnosis so that they were mainly entering into our prehabilitation phase of our service and being referred predominantly by the cancer nurse specialists. So that was possible. And what we also saw, we think we see about sort of 3/4 of patients diagnosed with cancer within the Harrogate area. There's always some that are going to be missed, and there's some that so there's some work to be done there with different specialist teams, and there's also some patients who perhaps actually they're not appropriate to come to us. So some of the ones on longer term maintenance therapy, where it's decisions made that they don't access the service. But of those referred, around about 70% actually come and actively use the service and are active with us. And these are referrals by disease site, which is an expected spread of diseases. I guess one of my main points of this slide is to show that although we have a limited range of oncology surgery done within Harrogate, we actually do have the full range of diseases within Harrogate, as you'd expect. And a lot of our patients then go on to have their surgery within Leeds, within our area. And in fact, that's had a ripple effect, and that ripple effect being that surgeons operating within the tertiary referral centres are asking why patients within that catchment area don't have access to the prehabilitation and rehabilitation that the Harrogate-based patients do. And so that has enabled us to be able to, where we've started to see that other centres within our area are starting to look to set up similar services, and we're able to help and support with that. And then just a few key positive findings. We have seen some outcomes. We've seen positive behavioural change. We've seen increased in physical activities, increased in functional aerobic capacity and flexibility. And the scores you can see there, and sort of anxiety, depression scores. But probably some of the most sort of the heartwarming side of it is the actual feedback we get from patients, both written in cards and emails, describing just what a positive benefit a service like this has had. And when we surveyed 100 of our patients recently, almost 100% said they felt safe and well looked after during the service. So I think the next steps for us, it was interesting to hear what Tessa had to say about outcome data. Getting formalised, standardised outcome is really difficult, and it's really, really time consuming. And so, you know, a standardised data set that we record, which if it could be standardised with other centres such as Manchester, and you know, I speak to John Moore a lot about this. Sheffield are recently set up, and you know, in Wales as well. Perhaps so we can start to pull and look at data on a wider scale. And of course, you know, opportunities to expand. I mean, we're an NHS service now, to expand the sort of services we do to non-cancer. So other surgical specialties with non-cancer, and also there's a huge overlap with ICU rehabilitation. So I'll end there. I apologise about the interruption with the cat, and leave it to any questions.
Thanks very much, Tom. It was really great, and you and Tessa have obviously done a huge amount and both got great services set up. I think we're probably all half very jealous and half wondering how on earth we would ever get anything like that in our own centres. So thank you for coming and sharing it. I think we may also have Scarlett McNally joining us, who's one of the deputy directors of CPOC, who is very interested in this area and has written a lot around the pros of exercise. One of the questions that's come up is about CPETing the patients post-prehab, and I think that fits into what both you and Tessa said, Tom, about data collection. And I mean, both of you made the point that you weren't going to talk about prehab itself. Do you feel that there's enough evidence now that we can just accept that this is a good thing, and how much do we need to keep measuring it? Because you both said it's an enormous amount of work just to keep collecting the data and sort of proving yourself, rather than being able to necessarily get on and just offer the service. It's taking out a lot of man hours. From both of you, if you start with Tom, perhaps what your thoughts are on, well, firstly, do you CPET your patients afterwards, and how much do you think you need to keep collecting this data?
We CPET patients predominantly in one area, and that is the area where they've been borderline functional capacity in the first set of tests. And the surgeons previously, it would be a variety of response, but actually a number of, we see patients who would have previously just been told they weren't fit enough for surgery. And what we've tried to ask is actually they push that decision making back by 4 to 6 weeks and allow them to go through a prehabilitation program, and then they're retested. So that to see whether those borderline cases they can have an improvement in the functional capacity. I guess the other side is it doesn't always have to be CPET. So there are other measures of aerobic capacity, such as we saw the slide from Tessa of the 6-minute walk test, and we also do that within the service, which is obviously much more cost efficient a way of doing it. And so that is tested at 2 time points at the pre and post prehab at the moment. Great.
Just out of interest, do you get many patients that go from being not in inverted commas fit to being fit for surgery?
We do see some, yeah, we do see some patients, and I think, I mean, it's one of the areas in the prehabilitation and exercise area that's interesting, is that the greatest gains are seen in the most unfit in the early stages, and actually after that, and anyone who knows who keeps themselves fit, that actually you can get really early gains quickly, but actually to try and go from being slightly fitter to more fitter is much harder. And the later gains are harder to see. So we can make real gains in the early period. And I think that's probably what Mike Grucock and his team were demonstrating with their early studies. But actually, if you then want to get fit people even fitter, that's hard work. And that's something we all suffer with.
Yes, indeed. Tessa, do you have any thoughts on your data collection and how far you need to keep taking it and proving yourself?
Oh, I think it will be something that evolves as time goes on. I mean, even just since we were seeing what we had in order to put into our business case, we've learned quite a lot since then about how it works and what might be most important to use. And I think what's actually worked out being very helpful is engaging with finance quite early on. So it'll be structured in different hospitals and maybe differently in NHS England, but we have a really, really good patient level costings team within finance, and I had no idea they were there beforehand. And they're very good at going through the hospital data. They can work out, you know, how much does a bed day cost, how much they're in the middle of working out for us, how much does pneumonia cost, how much does critical care bed usage cost. So I think it's important to do that because you do have to prove your worth, but it's just important to do that just because actually we all need to know what is going on in the perioperative period. You know, and if we don't measure complications, how will we know how many people are getting pneumonia or wound infections or whatever it might be? So I think it's a really unmet need. I don't know if anybody's solved it or got really good examples in their hospitals, but I agree completely with what Tom just said, that if there was such a thing as a standardized data set, I know there's been a lot published on it, but it can sometimes really depend on what you can do in your hospital and what works for you in practical terms as well.
And just partly for my own interest again, how did you find your finance person? Was that just by luck, or did someone point you in the right direction, or?
Yeah, the latter. So my colleague Rachel Barlow, who I mentioned earlier on, had previously, with some of her work, worked with them, so it was for us just using the links that she already had, or yeah, I would say to anybody, just contact your finance team and just find out who's doing that work, because I assume there would be the equivalent in most institutions.
Great, thank you. Possibly, well, for all of you, but maybe to start with Scarlett, there's a question here about the benefits of strength training, and so how do you choose what you're going to offer? And Scarlett's published quite a lot on exercise and surgery and outcomes. I don't know if you want to comment on that, and then perhaps Tom and Tessa on how you chose what you offered, whether it was just what you had available or whether it was based on the evidence in terms of your prehab, which exercises you used, which interventions you used. Scarlett, have you got any thoughts to start with?
Thank you, yes, and thank you for letting me gate crash this session, because I've been listening to 2 brilliant talks. I'm Scarlett McNally, I'm Deputy Director at Centre for Perioperative Care, but I'm an orthopaedic surgeon as well. Excuse me. And the strength question is really important, I think, because it's not just about the cardiovascular fitness for an anaesthetic. It's about being able to get up out of bed, so doing squats and being able to use your arms so you can use walking aids and that kind of thing. And it's difficult. I mean, I feel for all the people watching that haven't got an amazing service and just want to start somewhere. And some of it is just telling people that they've got to do squats, they've got to do, it should be at least twice a week squats, and the cardiovascular, just get out, go for a walk, just do something, and using the some of those assessment tools as a way of getting patients fitter. So tell them to do a 6-minute timed walk. Sit to stand on a chair, how many sit to stand can you do in a minute? Can you do more? Can you do more? It's almost giving people permission to get stronger and to get more active, because otherwise people are just scared. And all that we're talking about deconditioning, people are just not fit enough now to get out of bed after their operation, which is just a tragedy. So I haven't really answered the question, but it's a really good session. Thank you.
Thanks very much, Scarlett. Tom, do you offer strength training along with the balance and the cardiovascular stuff?
Yes, yeah, we do, and that it's really important. It's within the WHO guidance as well for fitness. So I guess the one point I don't know if I explained it very well in the slide, but the ABC trial for me, the issue that I sort of had with it, it was a very, very scientific approach to exercise, which in the context of a national trial, I understood. But actually taking an 85-year-old and putting them on an exercise bike and then telling them they had to achieve a certain heart rate for a certain period of time and then back down and rest and back up again, takes all the element of fun out of activity. And what I was trying to get across is that actually what we're trying to do is change long-term behavior, so that rehabilitation is actually prehabilitation for the next time someone becomes ill, and it was that side. So what we tried to do, and this is why our physical trainer, our lead physical trainer, was so important to us, and we were lucky that we had one who was desperate to be involved, is that they have an amazing skill set to actually to get patients doing exactly what they need to do from an exertional point of view, but in a way that they're enjoying it in a class and they're having fun within the full range of ages and comorbidity. So we do, like Scarlett said, we do have things such as sit to stand. We actually have a whole sequence of videos on our website of what we call kettle boy challenges. So whilst the kettle's boiling, there's a range of things you do, from squats to sitting to you can even just do bicep curls with things within the kitchen. So we have a range of videos that patients can use for that. But yeah, I think it is really important that it's not just cardiovascular fitness, because actually you start to limit the benefits that you see in outcomes.
Great, thank you, Tom. That sort of led on to something that I was thinking about as you mentioned the virtual, your videos and online. Have you had a good uptake with that? Because I think some centres have found it's worked well and some not so much.
So we had to do it. It's quite interesting. We have quite mixed views on this, because I spent quite a lot of time chatting with John Moore, who sort of launched at roughly the same time we did, and they went much more sort of online than we did. For me, again, it was about more than just outcomes from prehab. For me, it was about taking a vulnerable, isolated group and trying to bring them into a sort of a social environment in which they were achieving the things we wanted to prescribe, but in a way that they felt they were making friendship groups, peer support, and behaviour change long term. And I felt that delivering a heavily based, home-based exercise program lost a lot of that peer support element. Like, I mean, in about 3 days' time, I'm doing I've got to put an evening quiz together for the group, like in a social way, and those are the elements. They're not really anything to do with prehabilitation or rehabilitation, but these are all people who've met and come out and have been isolated and have made friendship groups through a service that's actually paid for by the NHS, and they all exercise and wellbeing is at its core. And that has a ripple effect. They bring their husbands and their wives and their children. One thing I didn't say, that lady who's since died who got the secondary bowel cancer. I mean, she turned up the second time to her exercise test with her son, who had a BMI of probably around 50. And of course, I was having discussions with him about health, well-being, exercise. So there is a ripple effect. And I felt that some of that was lost by a fully home-based program. But I do appreciate that's the most cost-effective way of doing it.
I mean, I don't think any of us would disagree with any of that. And the social and the mental well-being of everybody being in a group and meeting people, you can't measure it, but it equally makes it very difficult to justify it, doesn't it, if that's part of your, when people are looking to start these things off. Sorry, did you? No. So Tessa, in terms of what you decided to offer as your prehab, was it based very much on what you had available locally, or did you specifically go out and look for things that you felt were going to be the most beneficial intervention?
In terms of the interventions offered by the therapist and how it's sort of evolved. Yeah, it's a really good question actually, and I think this is another thing that will evolve as we go along. So actually we've only been up and running really since sort of end of September, early October. So we'd done some benchmarking and spoken to and read from others around the UK, and then and sort of put that to the therapies team and said, you know, we'd like you to incorporate these aspects because we know that the cardiovascular side is very important, but also as Tom's just been saying, it's more about engaging people in increasing physical activity. It doesn't necessarily have to be exercise if they don't or don't want to. And so we sort of left it to the therapist to design their own pathways in a sense. And what Josh has devised at the moment is they get three times a week. They have to do at least 30 minutes of a structured exercise. And if they're on Universal, then that's a home program that they get on with themselves, but they get regular follow-up from the support workers by phone. And if they're coming to the groups, then obviously that's more closely supervised. But then in addition to that, then they're encouraged to increase their physical activity. And they do use quite often the self-efficacy scoring and work towards improving that and the physical activation methods. And that's where the OT comes in as well, because as well as her work with fatigue and anxiety, she's very good at, sort of exploring what barriers there might be to people increasing their activity. And I've learned quite a lot about anxiety, now notice it much more with the patients on my lists, and how disruptive that can be actually to anything that you're trying to do for the patient in terms of any type of optimization and intervention. And that's often, very, very underdiagnosed. So an answer to a long-winded answer to your question, but it was sort of, it was led by knowing what was going on around the UK and looking at some of the evidence that we all know about, plus then what the therapists felt they could do. And I think once we have got over our hurdles with looking at the data properly, we'll be able to sort of see whether we've got from it what we expected to get. Are the 6-minute walks getting better, the Darcy scores improving, or whatever it is, and then maybe see what we can expand on within that.
Thank you. That's really helpful. I have to confess, I probably don't actually know what an OT does outside of.
I didn't know. I was educated. I must confess. Our Macmillan's therapies lead will be rolling his eyes right now. But I did say, why do we need an OT in the programme? And it's because they have a very good background and very highly trained within the mental health aspect of healthcare. And honestly, Claire, our OT, is amazing. I sort of hear her explaining to me what she's does, and it's sort of like mind Jedi powers of understanding how people think and can apply themselves, and really drilling down into what the barriers are. So it's effectively behaviour change, and like we've all been saying, it's about long into the future as well. So you don't just package them off after surgery and they go back to those previous lifestyle patterns.
Brilliant, thank you. We've literally got about, I think, a minute left. Is there, if I could just sort of a line from any of you, all of you, for people who are watching this now who've essentially got no prehab service, which I think is probably the majority of us, what can you start with if you're not going to be able to build this in a month, but what can you start with, interventions that you can do in your clinic and things like that? If you've got any advice along those lines, that would be great. If you start with Tessa, as you're on my screen at the moment.
Yeah, that's a really good question. Gosh, I think if you've got limited resource, but you could spread it quite widely, then try and use some, or either use existing or develop your own online resources. We do already have a website, which was again therapies led, which has got a lot of signposting type information on it. Now there's sort of pros and cons of signposting, whether actually that works and whether people take it up and continue. But that's certainly one place to start. And I think just start where you can if you've got interested people around, whether it's a physio or personal trainer locally, and just see what they can do. So use your existing resources rather than worrying about building a massive business case to start with.
Thank you, that's great, that's really helpful. Is your website something that's accessible to people who aren't in your area, or is it just for your patients?
Oh, that's a good question. It's www.keepingmewell.com, so give it a go.
Thank you very much. Very helpful. Tom, have you got anything else to add or any other ideas from that?
I mean, I think similar to this, I mean, we do also have an active website, the Active Against Cancer. If you just search that, it comes up, and that has a number of videos in there. I mean, there is a wealth of information on the internet. It's how do you actually get people to actually access it and take it in and engage with it. And there's stuff there from the Royal College as well. I mean, I was once told by an old cardiologist that everybody should have a dog, give it half its food, and take it for a walk every day. It kind of rings true, really.
Yeah. Oh, that's great. What I might do, I'll put both of your websites in the Q&A in a moment. Scarlett, is there anything you would like to add into that, and then I will hand over to you?
Thank you. Yes, just a different angle completely about training up the staff to talk about it, because sometimes it's a bit scary. You think you don't have to be a physical trainer to be able to get started. Can I recommend movingmedicine.ac.uk? And that teaches people about how to give, in a 1-minute consultation, how to talk about exercise. If you scroll down through the conditions, one of them is perioperative care, and we've helped them on that. So that's movingmedicine.ac.uk, and then get other people to do it. So the receptionists, the healthcare assistants, that sort of thing, they go on e-learning for health and look at making every contact count. That's e-lfh.org.uk, and anyone can do it, but it means that the porters can talk to people about smoking or something without being shaming or something. It's a way of having a conversation, because we all need to do it, if you see what I mean, and not just rely on the patient to change their behaviour. No, thank you. Brilliant session. Thank you.
Thanks, Scarlett. I will put those in the chat now, and I will leave it to you to introduce Ramani. Thank you, Tessa and Tom. That was brilliant.
Thank you. And Ramani, thank you so much for coming to speak to us today. I'm just going to let you introduce yourself, because I've got so absorbed that I haven't got what you're speaking about in front of me. So go for it, please. Thank you.
That's a really good sign, Scarlett. Thank you very much. Hi, everyone. I'm Ramani. I'm I'm an anaesthetist and intensivist by background, and today I'm here, I think, in my NHS England capacity as National Clinical Director for Critical and Perioperative Care, to introduce the new NHS England and Improvement sequin for dreaming, or drinking, eating and mobilising within 24 hours of major surgery, which will come into effect from tomorrow, from the 1st of April, the beginning of the new financial year. What is dreaming? It is aimed at reducing length of stay and complications after surgery. The ambition is that as many patients as possible should dream, so drink, eat and mobilise, within 24 hours of surgery ending. And we've defined in the PQIP study, which I'll talk about a little bit more in a moment, we've defined dreaming as drinking free fluids, eating a soft diet and mobilising with the maximum support of one person, assuming that you were fully mobile pre-operatively, within 24 hours of the end of surgery. And you could conceptualize dreaming as sort of ERAS, or enhanced recovery after surgery light. Many of you will have been directly involved in efforts to implement enhanced recovery. It's been in the United Kingdom since the early 2000s, since the Department of Health supported programme that was led clinically by Monty Mythen and Alan Horgan from Newcastle. In those days, enhanced recovery could be conceptualized as 15 to 20 different individual elements that could be brought into 4 themes around preoperative, intraoperative, postoperative, and later postoperative care. What we found over time is that while there was a huge amount of enthusiasm around enhanced recovery when it was first brought in, there were financial incentives to implement it. And then when the financial incentives were removed, lots of places really struggled to maintain the momentum with making sure that enhanced recovery was a real part of the pet care delivered to patients. And then there have been some other problems as well. So in those 15 to 20 different elements, there's a bit of low-hanging fruit. So individualized pre-op assessment for all patients, temperature management in theatre, antibiotic prophylaxis, for example, minimal access surgery where possible. Most of that low-hanging fruit has been eaten pretty much everywhere. And then there's some stuff that remains controversial. So goal-directed hemodynamic optimization, for example, for anaesthetists, avoidance of abdominal drains for surgeons, obviously in colorectal surgery. And then there's some other stuff which is achievable with effort. So the key thing there really is early return to usual homeostasis, which is what dreaming is all about. So PQIP I've mentioned briefly. It's a national research study which looks at patients having major surgery. Thank you to anyone that's contributed data to PQIP. It's hard work for local sites, but I think this is an example now of how the hard work that local investigators have put into it is really achieving results. We have a publication coming out in the British Journal of Anaesthesia soon, in the next few weeks, which highlights an analysis of more than 22,000 patients enrolled into PQIP and the relationship between dreaming, as I've just described it, and post-operative outcome. Primary outcome that we looked at was length of stay, but we also looked at complications measured both using the Clavien-Dindo scale and the post-operative morbidity survey. Now, one of the things that people often say about dreaming or enhanced recovery in general, if they're a bit hesitant about the ambition, they wonder about whether or not actually things like whether or not you dream within 24 hours are entirely predetermined by patient factors. And it's true that some patient factors do influence whether or not a patient dreams. But most of these in our analysis we found to be modifiable, such as, for example, preoperative anemia. Preoperative anemia predisposes patients, it's associated with lower levels of dreaming, but as we know, there's also a sequence for anemia management, and it's an important target that's also been laid out by CPOC. There are lots, more importantly, there are lots of hospital level process factors which influence it. And of course, all of these are potentially modifiable. And some stuff that is really critical that we found, like, for example, immediate post-operative pain in recovery, tubes, nasogastric tubes, drains, and so on, they all predispose patients to not dreaming within 24 hours, which is kind of intuitive, of course, but it's useful to see the data in black and white, and you will see that, as I say, in the BJ in the next few weeks. And these are important targets for improvement, and these are a few of the research team at the bottom here. And the other reason why it's an important target for improvement is because of this variation that we see. So obviously, enhanced recovery and quality improvement both are about reducing variation in the delivery of care. We took from that cohort of 22,000 patients, the just over 7,000 patients that were having a very homogeneous group of 4 colorectal procedures. We looked at hospital level at the proportion of patients dreaming within 24 hours in just those 4 procedures. And you can see here, each of the lines, each of the bars is a different hospital taking part in PQIP. And you can see the gigantic variation there is between trusts. So again, some variation is to be expected, perhaps based on patient characteristics, but I'm sure not this level. And so there, again, lies the real opportunity for improvement. And if you needed any further convincing about the value of dreaming as a quality metric, this takes those data that I've just shown you and analyzes them in a particular way to basically divide hospitals that you've just seen on that bar chart into 5 groups based on the proportion of patients within their hospital that achieved dreaming. So group 1, you can see there on the left, is the hospitals where the lowest proportion of patients were dreaming, so up to 33%, and over on the right hand side includes the hospitals that were the best performing as far as dreaming was concerned, in that very homogeneous group of just over 7,000 colorectal patients. And what you see here is that the median length of stay across the board was 6 days, but the variation between group 1 and group 5 is 2 days in terms of median length of stay. So if you're in a hospital where dreaming is part of the culture and you've got a very high proportion of patients that dream, your median length of stay after this group of colorectal procedures is 2 days lower. And what's also interesting is that although there is an association between, a strong association between whether or not you dream within 24 hours and whether or not you later develop a major post-operative complication, if you look at the bottom there, at the incidence of major post-operative morbidity in those groups of hospitals, there's very little difference between the hospitals and their post-operative morbidity rate. So what that tells me is that there is enough that we can do from a hospital level in terms of sorting out our processes to encourage dreaming and reduce length of stay, irrespective of the post-operative morbidity characteristics of our patient group. So there's enough for us to target there within our gift. Now, I'm guessing that most of the audience are anaesthetists. Why should this be our issue? That's because all roads end in dreaming. All roads that we and the surgeons are involved with end in dreaming. So preoperative health screening, undertaking that anemia assessment and treating it. Empowering patients, shared decision making, very important part of the preoperative pathway involving both surgeons and anaesthetists. Optimization of comorbidities that might predispose patients to not dream, surgical techniques, so minimal access surgery, anaesthetic technique, and analgesic strategy. These are all things that will help patients. If we get these things right, patients will be more likely to dream, and these are all things that are within our gift. So the sequin details are here. If you just put sequin into Google, you'll get the documents that are relevant. And on the top there is the basic overview of what the goal is. And on the bottom on the right is the more detailed information. So in this instance, the sequin is going to apply, you can see the denominator here, to patients having colorectal resection, cystectomy, nephrectomy, hysterectomy, and so on. You can read the procedures there. And we've also got a list of OPCS codes in a separate document for the purposes of knowing which patients go into your denominator. Patients who are sedated within the 24 hours after surgery are excluded, obviously, from the denominator, but otherwise all patients are included. And the ambition is that each trust should get to 70% of their eligible patients dreaming. Obviously, we'd like places to do better than that, but the sequin payment is capped at 70%. So the minimum that you have to achieve to get the payment is 60%, and the maximum you'll be paid for is 70%. So wearing my college hat, if I have one, we're going to have a webinar which is led by colleagues from the PQIP team on the 5th of May at lunchtime, where we're going to try and bring clinical colleagues together to try and help really shape how we help implement dreaming going forward, with some insights on the PQIP program so far, because we've seen a steady improvement in dreaming rates over the years that we've been running PQIP, and we've gone to sites to find out exactly where the good sites, how the good sites have achieved their high dreaming rates. And we're also working with the Fitter Better Sooner team. So this is the preoperative information that the college has developed to support patients prior to surgery. And we're going to add some stuff in there about dreaming, because what I'd really love to see, I think we'd all love to see, is in the same way that if you book bed and breakfast at the hotel, if you book room service at your hotel and then they didn't turn up at 7:30 with your tray, you'd ask why not. It would be great to get patients to the level that they can also ask, well, I was expecting to have something to drink or have something to eat or be able to get out of bed within 24 hours of my operation, and it doesn't seem to have happened. And why is that? And I'd love patients to be able to get to that stage. And just to finish, these are some examples of the information that we've gathered from hospitals where one of my colleagues, Georgina Singleton, who's a anaesthetic trainee, who's been doing some research with PQIP, has gone to hospitals or called them up and said, how have you done it? How have you achieved your high dreaming rates? And these are some of the insights that we've gained. So the prescribed cup of tea in recovery, the dining area on the ward, the hospital gowns to try and getting rid of the hospital gowns to try and encourage patients to mobilise, and so on. So nice, simple stories that we've gained from hospitals that are doing well, that will try and again sort of support the spread and adoption of before. And all of this is also in the PQIP report most recently published. So that's it from me, Scarlett, but very happy to take any questions. Thank you.
Thank you very much, Ramani. And I'm going to give your introduction. I should have given at the beginning, just so everyone knows what you're doing. So Ramani's Professor Ramani Munisinger, National Clinical Director for Critical and Perioperative Care at NHS England and Improvement, Professor and Head of the Centre for Perioperative Medicine at University College London, and the Director of the Health Services Research Centre, National Institute for Academic Anaesthesia at the Royal College of Anaesthetists. And that was a brilliant talk, because it's about using data to get change and kind of demanding one thing that actually requires a whole system to be changed and different individuals to talk to each other. And that's actually what today's really been all about. So I'm going to check with Alice if we've had any questions on the Q&A that need answering. I can't see any from here.
I don't believe we've had any questions as of yet.
Okay, thank you. Well, on that note, I might close. Thank you again, Ramani, and thanks to all the other speakers and chairs, and thanks to Alice and Carly behind the scenes and Jodie who've run today. There will be certificates. You'll get a feedback survey soon, and you get your CPD certificate after you fill out the feedback survey. All the talks have been recorded, and you'll have access to them in a few days' time for the next 6 months. Now, I particularly asked to close the event because I'm very aware it's sometimes a little bit like watching the Olympics. It looks so good, you just sit back and think, well, I couldn't do that. And it's been lovely hearing throughout the morning how people have managed to change things in their trust, and little tips about how to deal. It's between the cultures, between the silos, that we really need to work. And just working out what other people's problems are and getting data seem to be key. And little I've picked up, I've got a whole list of things I've written down. Things like helping other people with their mortality, morbidity meetings, going to different groups, audit meetings, finding out what other people have challenges with, so you can almost express the thing in the language of the others. Because sometimes it can feel that one gets in a very binary position of operate or not operate, and actually it's the preoperative optimization that goes alongside the assessment that's really important, and getting the prehabilitation right back to the rehabilitation right back to prehabilitation. So that's really enough of me waffling on, because it's been a really superb session, and I'll certainly be going back to watch some of it later. So thank you all for watching, presenting, and being part of it, our whole network, changing the future of how patient care is delivered. Thank you.